Evening to one and all. It is a real pleasant sight to see such an august gathering on a Sunday morning for this Hooghly District Outreach CME of OSWB. I am Dr. Shudipta Mitro, chairing the scientific committee of OSWB presently, and myself with Dr. Shibashish Dash, our chairperson of District Outreach Subcommittee, extend a warm welcome to each one of you here. This journey of ours had started 8 years back in 2018 with the blessings of the seniors, the then secretary, Dr. Shubhashish Nag, the president, Dr. Rutish Chandrapal, and the other seniors like Dr. S.N. Mishro, Dr. Shukumar Mondol, Dr. M. Dash Ghosh, and many of us who are here, Dr. Shamul Pandey sir and the others. And this journey did not stop even during COVID. We had virtual CMEs, and all the credit goes to each one of you who have made it successful. So as we continue our journey, so not wasting any more time, this time the main crux of the CME is that we are giving out CME credit points the first time in this district outreach program. And we will start our program with the felicitation of our president, Dr. Arup Chakraborty sir, by our secretary of OSWB, Dr. Aniruddha Maiti. Kindly Aniruddha and Dr. Arup Chakraborty sir, please come on to the dais. Can we have a round of applause, please? Thank you, Aniruddha. I would directly like to go into the program. Before that, we would request the President and Secretary, if you want to please share some words with the crowd. Sir, please.
District outreach was a very good initiative taken by OSWB. But what has really happened, that remote districts not been able to be catered to, especially Purulia and other far-off districts. But we have been able to do it in North Bengal, maybe doing next month in Bankura. It's a very good initiative so that the local ophthalmologists get involved. But most of the places, the medical colleges don't have PGTs. So the attendance from there is pretty low. But last time when we had in Malda, there was a good attendance from from Murshidabad Medical College.
From North Bengal, from Shiliguri.
And a lot were there. So it's a very good initiative. I think we have to have more programs of this sort, and it's a very important and very, I think, fruitful contribution of OSWB for its members. Now, I welcome you all in today's meeting, and it's a hell of a job done by the local committee and our chairman and Shibashish. So, welcome you all.
Aniruddha, if you would like to share some words? No? I would like to introduce the organizing team here. I would like to call them here because without them, this was never possible. Over the years, they have been the pillars. Dr. Shamul Pandey sir, please sir. Dr. Arup Bose sir, Dr. Saurabh Sharnal, Dr. Pinaki Nag. Sir, please, we want all of you on just before we start. And Dr. Shumon Mukherjee, unfortunately, he is not here, but he has really joined hands with us to make this program a success. And he is the observer from WBMC also. Yes. Thank you all. And Shibashish, would you, as the chair of District Outreach Subcommittee, would you like to share some words? Yes, yes.
Good morning, everyone. So, welcome to the District Outreach Program of Hooghly. Every year we look ahead to this program, not only for the excellent scientific sessions that we have during this program, but also for the excellent food and hospitality that we get at every time we have done a program at Hooghly. So without wasting much time, we'd like to start off the first session.
I'll come.
So I'll hand over the session to Sudipta Di.
The first session is all we need to know about cataract. And to co-moderate the session is Dr. Pinaki Nag with me. The chairpersons I would like to call upon the dais, Dr. Shamul Pandey sir and Dr. Parag Mukherjee sir. Please occupy the chairs. Sir, এটা তৈরি হয়ে আছে sir, আসুন please. The panel, Dr. Co-chairperson, Dr. Mondira Shamajputi madam has not yet reached. Panelist, Dr. Shomnath Dash. Yes, sir. Please come in front. Dr. Shobhoshachi Ghosh, sir. Dr. Shonji Banerjee, Dr. Siddhartha Bose. I hope, please, the panelists, please come in front. And I would request Dr. Pinaki Nag sir to introduce the first speaker.
Thank you, Sudipta. It's all for you, your initiation, everything. We're here, all of us, and hopefully we will have a very enjoyable day. Before we go into the academic session, I just need to make a few announcements. There is washroom just right beside the door. You have to go all the way around. There is a washroom there, and some of the others on the back side. And there is a break, not actually break, there is a running time where you can have snacks, and then after we finish, and then we go for the lunch. Now we are going to start our academic session. The first speaker does not need any introduction, not from only us, but around the world people knows it. Even from Brazil, even from Japan, even from Middle East, everybody knows him, Dr. Pradeep Mohanto, because of his very, very nice YouTube videos. We are all very, very benefited from that. And he is the, at present, ARC member. So he is going to talk about a paradigm shift in soft cataract, phaco and phaco-chop. Why and how? Like many other initiative or many other invention he did, he has always tried to modify the way we do our cataract surgery and other surgeries. So I'm sure you'll all enjoy his new technique. Thank you. Thank you. All yours.
My deep respect to the seniors and my beloved friends. We know that for beginners, we suggest grade 3 nuclear sclerosis to begin with. That means soft cataract is not easy for beginners. So there are some situations we face a lot of problems in soft cataracts. Let us see the role of pre-chopper in such cases. Now, why to learn a new technique? You are doing it somehow, soft cataract, you are managing well. Why should you learn this new technique, how to pre-chop the nucleus and manage it somehow? See, if you try to make a trench or if you try to hold the soft nucleus, you end up with this kind of picture sometimes. Not sometimes, many times. You make a bowl and then you do again hydrodissection, prolapse one side of the equator of the nucleus and manage it somehow. So you face bigger problems in diabetic gummy cataracts. Cataract is soft, you make a deep trench, but even after making a deep trench, the cataract doesn't want to separate. Diabetic gummy cataracts are really painful. And cataracts with IFIS, soft cataracts. You try to make trench, whatever you want to do, people become small, and then you don't know how to do. With jonular weakness, with small people, these are the situations you face more problems in soft cataracts. The solution is pre-chop the nucleus into pieces and then introduce your handpiece into the anterior chamber. This pre-chopping is not new. Dr. Akahoshi is doing it for 3 decades. Maybe 30 years back he started. All of us, maybe we have started, some of us, sometimes we have tried pre-chop, found it not very comfortable, and then we resorted back to our old technique. And the Thing is, the original Akahoshi pre-chopper costs 1,000 US dollar. That means about 85,000 rupees. And the pre-chopper that our Indian companies make, copy of the original Akahoshi pre-chopper, it's not so, doesn't open so well. So I made my own pre-chopper, designed my own pre-chopper and nucleus sustainer. The left side is the Akahoshi pre-chopper and the right side is mine. I designed it 1.5 years back. The anterior edge is the cutting edge, bottom is rounded, and the back surface is blunt. And you need a nucleus sustainer. It is a ball-tipped. The tip length is 1.8 millimeter. The pre-chopper also has the same length. You just have to practice some hand movements. You just have to hook the equator and you have to engage the pre-chopper just in front of the main wound and pre-chop the soft cataracts. Let us see some videos. This is a grade 2 nuclear sclerosis. You introduce the nucleus sustainer, introduce the pre-chopper, hook the equator. This is real time. Rotate, pre-chop another side, rotate, pre-chop another side, and in 40 seconds, you get 4 pieces. Any other technique you do, it is going to take longer time. And now you just have to go in and emulsify the pieces. But you have to go in and separate the pieces, otherwise they don't want to come to the tip. So what you do is, you go with the hand piece, rotate the pieces, and some of the piece will be free and it will come in out of the bag. And then it becomes easier to emulsify the pieces. Ultrasonic energy is very minimal. You need only 30% ultrasonic energy in such cases. You can keep vacuum about 400 and flow rate about 40 in such cases. And at no point of time the tip is going to periphery. It is always in the central 3 to 4 millimeter safe zone. Little harder cataract, grade 2 plus, also can be managed by this. Do hydrodissection. If you can manage to do a hydrodelineation, just hook the golden ring and pre-chop. It's a joy. Once you learn this, it's just child's play in your hands. So I will insist all the surgeons who are doing soft cataracts, all of us are doing soft cataracts, and where from the money comes? The money comes from soft cataracts. And premium lenses, they come with, those who come for premium lenses, they come with soft cataracts. In those cases, you need to do a 5 millimeter rhexis, but in 5 millimeter rhexis, the nucleus doesn't want to come out into the anterior chamber. So in the bag with 5 millimeter rhexis, you can pre-chop and manage the nucleus. And little harder cataract, grade 3, also can be managed by this technique. This is a cataract which you can hold and chop. But if you want to decrease the use of ultrasonic energy, just do hydrodissection, rotate the nucleus, and pre-chop. Initially, what will happen is antechamber will become shallow in your hands because you will press the wound and visco will come out. So what you do is just make on cut, come out, inject visco, and pre-chop again. Rotate with hooks. So if you just practice this in 4 to 5 surgeries, I am sure all of us are expert surgeons and you will find it very useful. So I insist all surgeons who have not yet started pre-chopping, they should start it from next week. And this is commercially available. Plus Surgical is making a beautiful pre-chop just for 4,800 rupees. One set is made available. No financial interest, but I want to make it available to every one of you. Thank you very much.
Thank you, Pradipda. Your surgeries are as brilliant as ever. I don't know, anything you are given in your hand, I think you can do the same sort of thing. You don't even need this thing. Every surgeries you do, whatever we've seen in the YouTubes are brilliant, and so it is. Now, if anyone has got any questions, please on this.
I've got a. Oh.
Good morning, sir, and it's a very nice presentation. Sir, have you tried this operation in case of your immature cataract or grade 2 cataract with zonular weakness? One quadrant or two quadrant weakness, you are applying the CTR, and you can whether you can apply this technique in this situation.
You do the pre-chop before applying the CTR.
Okay.
Because you inflate the, you fill up the antechamber with visco. In zonular weakness, there is strong capsulocortical adhesion.
Yes.
So you bimanually rotate the nucleus and then gently hook the equator and pre-chop. Otherwise, if you place the CTR first, you can hook the CTR, I don't know, then it can face a lot of problems.
So you have any
It
experience?
is possible. And in weak zonules, we should pre-chop. Otherwise, there is irrigation pressure on the zonule. And as we try to use vacuum and hold the nucleus, there can be some push and pull in this side and that side that can cause more zonular tear. That is what I think.
Okay. And another one is that in case of pre-existing posterior polar cap or the posterior PPC, so is it applicable in this situation?
Yes. PPCs are usually soft cataracts. You just do hydrodelineation, pre-chop the nucleus, manage the nucleus, and then manage the epinucleus.
Okay, thank you.
Excellent presentation and very good videos. I want to ask you two things. Why have you made it 1.8 millimeters? What's the basic idea behind it?
It is enough depth to crack the nucleus, and I didn't want to touch the posterior capsule in the periphery. In the periphery, the depth is about 2 millimeter. In the center, it is about 4 millimeter in the central part. In the periphery also, I didn't want to touch the posterior capsule.
No, but why not 1.5 millimeter, which we normally use as choppers?
1.5 millimeter, there's 1.7 millimeter is also there. In some cases, you will fail. It will not go to enough depth.
And second one, you said that you need to dial the nucleus after you have pre-chopped it. But the idea is these cases, soft cases, we are not being able to dial it. That's why we are using pre-choppers. So if you can dial it, you can easily chop it, hold it and chop it.
Please watch some videos of Dr. Neto Rosatelli. What he does is, he goes to the equator with the nucleus sustainer and sweeps around and spins. So it is very safe, and if we practice this nucleus spinning in some cases, it will be very easy to rotate. And if we manage to do hydrodelineation, just go hook the golden ring, hook the nucleus and pre-chop. I hope this answers your questions. Have I missed something?
Sir, I have one question.
Yes.
Sir, have you tried it in a young patient with soft cataract without a formed nucleus?
No, in those cases it will not work. It's just, it will go cut, it will not separate.
Sir, I'll be very quick. Sir, this is an excellent equipment for beginners and all. But for experienced surgeons, like what I do nowadays, since I do a bit of premium IOLs, in soft cases, I use my phaco tip as a pre-chopper only. What we do in hard cases, we go in the middle of the nucleus and chop. But if you want to use the phaco tip as a pre-chopper, just sub-incisionally you hook the cataract or the nucleus with the chopper. The rexis should be more than 5 millimeters, and take the chopper beyond the equator, and
that is the point.
Yes.
The nucleus rexis should be more than 5 millimeters.
Yes.
But in premium lenses, you want it 5 millimeter.
Yes.
So
It should be
if you
at
want
least
it 5
millimeter.
millimeter, this is the tool you should keep in your trolley.
Yes.
Yeah. One thing I need to ask you, when I tried, you given me the thing. If it is very soft cataract, what I found when you actually pre-chop, then when you try to separate, then it can't separate. You know, the four quadrants, you can't make it, it just all gets smudged up. So that is one thing. And for soft cataract, what I feel exactly the way Siddhartha said, just use the phaco tip as the chopper and use the sustainer and push it, and that way you can actually do it. But for grade 2, grade 3, it's very difficult to do. And other thing, I always get scared to do the sustainer. As you said, it's less than 2 millimeter. But even when you are pushing it, how deep you are going, you can't always make.
You just hook and go to the posterior surface. Even if you touch the posterior capsule, the instrument is such that there's a ball and smooth ball at the round body tip, nucleus sustainer. Even if it touches the posterior capsule, nothing is going to happen. The instrument has been made in that way. So don't be scared, try it.
Thank you very much. Thank you. Before I call the next speaker, I forgot to mention one thing. There are actually 10 minutes for each of the topics. The first 6 minutes is for the speaker, and then the question answer session for another 4 minutes. So please try to stick into that. And the next speaker is none other than the president of OSWB. Now he is as you all know, he is very, very approachable, very jolly, very helpful, and in fact, he is my mentor because he was my teacher when I was in Ramkrishna Mission, and since then he is my dada cum mentor. So he is going to talk about phaco emancipation in raised IOP. Arupda, dais is yours.
Good morning, everybody. I think Sudipta meant that I should speak on. The intraoperative IOP, because pre-op IOP you have to deal in differently. Now the very important thing is that how would you assess during your detailed examination in the OPD? First, if you see that the IOP is high and you expect an high IOP. IOP is not high during that time. Then you can go Diamox pre-operatively for 2 days or maybe 1.5 days. Before taking the patient to the OT, you can give 1 bottle of mannitol. It's mandatory. If you feel like. This procedure, I was doing it more than 20 years back when I used to give all my patients Diamox 2 days before. And Diamox has its own complications, so I stopped. And I have not using mannitol for last so many years. Only in some special cases where during operation, if you find that the IOP is going high, then you can definitely give mannitol. And during surgery, you can give mannitol, which I use now, or anterior vitrectomy. Of in some situations, you may have to delay or postpone the surgery for some time. Take the patient to the ward and bring the patient back after half an hour or so. Let the hyperosmotic agents work. The IOP comes down, then you can do. Now, when do you expect? Look at the AC depth, which normally we ignore when we see the biometry report. If the AC depth is low, I think below 2.4 or something, you be a little cautious. Small eye, of course, you can expect in all small eye patients. When the patient have a pre-op PI done in the surgical, you don't remember, but when you are doing the surgery, you see there is a PI done. You expect that something might happen. In pseudo-exfoliation, subluxation of the lens, and some situations, especially when we were doing ECC or when we were doing, not before the pre-phaco area or early phaco time, this bulky patients with reduced oxygenation, the pulse oximeter shows the 94, 93. These patients are going to have a temporary rise in IOP. So you ask the patient, we used to ask the patient, apni bhalo kore nishwash niন, deep nishwash niন, and in some situations it's definitely helped. There's a prolonged surgical time, you can expect that IOP will may rise, and in elderly patients. You can't make it, but This which one shows that in the intraocular rise of pressure in patients who have been having hypoxia. This has been documented that those patients who are having hypoxia, they tend to have an rise in IOP, not to that extent, but between 1.2 to 3.4. That is the IOP rise during intraoperative period. Now, this is a video. You can see this patient is a classical case of moderately good dilation, but it's a classical case of pseudo exfoliation. কোথায় করবে? অ্যারোটা কাজ করছে না তো, মাউসটা কাজ করছে, মাউস দিয়ে করতে হয়। ও সরি সরি। Now in this patient, I did on the left hand side the side port, on the right side I did the side port, and then I saw the IOP was very high. I knew that I would not be able to I was trying to do the main wound, but it was so high that I just couldn't insert the main to do the main incision. I waited and then asked my anesthetist to start a mannitol. I started mannitol in jet and give 350 cc's of mannitol. After that, the AC was reasonably formed and I could do the rhexis. But during I was doing the rhexis, I could see the patient had very, I should say the zonular dehiscence, and it was basically the whole of the nucleus was wobbling. So I reduced the IOP. I normally do under 20 millimeter. Sometimes in cases when I find it difficult, I increase the IOP, but normally I try to do in 20 millimeter, and in most of the cases it doesn't give me any problem. So I was doing it very gently because whatever I'm trying to lens, the whole of the nucleus was rotating. Now you could see the pupil is becoming smaller. Now this is how the nucleus was taken out. I am not going further into it because it was a case of subluxation, so it was dealt with in a different way later on. Now, vitreous hydration is a very common thing which happens, and it has been shown that vitreous hydration after phacoemulsification causes retinal detachment and the increase in the intravitreal pressure. I think it is not visible properly. Anyway, I would just read it out that vitreous hydration has three main consequences. The first is increased difficulty of cataract surgery, especially appearing during the last part of the phaco procedure. Because of the posterior pressure due to increased vitreous volume, we find it difficult to enter the anterior chamber with the phaco tip. The problem is often faced by further increasing the bottle height and thus worsening the situation. In addition to small lens fragments pass into the vitreous cavity with irrigation fluid, these fragments can always be seen behind the posterior capsule floating in the anterior vitreous. Patients frequently complain about increased vitreous floaters following cataract surgery. In the worst cases, it can be difficult to implant the IOL also. So this is the documented cases that we have. What happens when we are doing the phaco, the IOP is high or we have increased the bottle height, and we feel that in this situation we have a very good AC depth, and in this situation if the surgical time is prolonged, then the fluid goes behind the vitreous through the zonules and it increases the vitreous volume. When it increases the vitreous volume, the AC becomes shallow, and to such an extent, sometimes there is a vitreous bulging. And in these situations, you have very little option but to go for different procedures, which I will show now. Now, this is a patient. This was a reasonably hard cataract, and it was a leathery one. So the surgical time was slightly prolonged, and I did this at a slightly higher IOP, maybe around 50. As far as I remember, it was 50. The video display is not there. After some time, to this stage, it was reasonably okay, but the AC was definitely shallow, and patient had a 25 diopter IOL power. In this situation, I could see that it is now becoming difficult. So I put on some viscoelastic, tried to increase the AC depth, and placed the nucleus in a slightly different position so that it is away from the center of the lens. I could do this, but still very difficult, getting difficult and difficult for me. And at this stage, I just stopped. Now you can see there is slight amount of cortex and there is a small bit of nucleus here. So then I thought that if I can do the IA and remove the cortex and put the lens and take out the nucleus later on. But you could see I tried doing, and the vitreous was bulging like anything. The reason could be that the prolonged surgical time, one reason. Second, the slightly small eye. Then I thought there's no way I have to abandon the surgery, but my vitreous surgeon was there close to me. I called him. You know, everyone can do this now. This is the first time I had to take help of a VR surgeon. So I know from next time onwards I can do this very easily. And he did a bit of vitrectomy with the anterior vitrectomy cutter only. And after doing this, the IOP came down. And the IOP work came down, and we could manage the removing of the cortex. And here also, the cortex was removed. And he said, Arubda, now, my friend Vikash Basu, he said, Arubda, now the chamber is well formed. You can do it easily. So I am taking out the vitrectomy. I'm not doing any more vitrectomy. So I put in the lens, and after that, the remaining part of the nucleus was removed. Now things are very easy. Thank you very much.
Thank you, sir. These were beautiful videos, very messages were very clear, and teaching videos, because this is something that we face very often, I would say. And the first few slides that you showed, I will say that they are very important, that when we look into the eye, sometimes it is important for us to see the AC depth, take a bit of the history of the patient. Before I go to our panelists, I would like to share my own experience just 2 weeks back when a patient was getting operated for mature cataract. On table, I found it was looking hard. Fortunately, I fared, and just outside when I was asking my staff to tell the drops and all that, the patient party came up with some anti-glaucoma medication, showing it to us that will we continue this drop to us. No idea this patient had glaucoma, this patient was ever treated for anything. So we were just shocked. So things happen in this way, as you said, very clear message that history, even if you are in the best of hands, you might miss. So better look at the AC depth and also the small pupil, the shallow AC. Now for the panelists, yes. Oh, okay. Pradeep sir.
On the table, mannitol. So the patient is on the table and you have started mannitol. How many minutes you have to wait to IOP to come down?
I normally wait for about 200 ml cc of fluid as given. After 200 cc, you will see there is some change. But in these situations, I try to finish up 350 cc of the whole bottle because there is a rebound. So don't wait for don't stop after 200. You reduce the volume, the flow rate, but up to 200 you give in jet. And that takes about 5-7 minutes, it comes down. By 10 minutes, this is workable.
Okay.
Yes.
So one reason for this is called posterior infusion syndrome. The hydrofluid or the irrigating fluids goes through the zonule region into the vitreous cavity.
There is a bulge space.
That's why the bulge occurs.
That's why.
And sir, I mean, your technique of this using the cutter is the most effective. It becomes very, very comfortable. I mean,
Yeah, I think in this situation there was no other option
there is
except
no other
for
option. It's called
technique.
intraoperative hard eye, and when that occurs, there is no other option.
And the last patient, I gave 350 cc of
And
mannitol. It
doesn't work. Doesn't work. Mannitol doesn't work, sir. In this situation, mannitol doesn't work. Even if you wait, even I have done what I have done is I have shifted the patient to the ward, given him mannitol, waited for 45 minutes, entire bottle. Even then, it doesn't work.
It didn't work.
No.
I had to do cutter.
Shayan, you are talking about the fluid in the misdirection in the Barger space.
Yeah,
There is space behind the posterior
through the
capsule.
zonules, yes.
Through the zonules, behind the posterior capsule and anterior surface and anterior to the
And it
vitreous
goes into the
space.
vitreous,
Yes,
I mean,
it is very easy to manage because it doesn't require any mannitol or other things. We put viscoelastics, particularly high molecular weight viscoelastics in the capsular bag and wait for a few minutes. The chamber will depends because the fluid will again come back to your original.
Now, in
Volume of the vitreous has already increased, no?
No,
The volume of the vitreous has already
on-
increased.
If only it collects in the Barger space, that you will
Then
see,
that's okay,
then
fine,
it's.
yeah. But if the volume of the vitreous is
Then you
increased,
cannot
it's not
reduce.
going to
Yeah, correct. And I think some of us here, I think Dr. Dotto, Devashish Dotto, they had advocated some massage at the, to reduce the hard eye anyway, it might be, at the limbal region, so you can reduce a bit of the hard eye in case it has not gone to the vitreous sufficiently to hydrate the
But
vitreous.
most of the
I
cases,
think
that even high volume viscoelastic doesn't work. It won't come out.
it's different case where some amount of there's some amount of hard eye, and in interest of time I think we should move forward.
I'll be very
And
quick.
I request one second. I request Dr. Sugotopal to please come for the next presentation on the dais. Siddhartha?
I'll be very quick. I want to ask Sir, Arup Sir, I know many surgeons who are using Diamox preoperatively. I find Diamox is very dangerous. If it causes Stevens-Johnson syndrome or anaphylaxis shock, the patient will be in trouble and the doctor will also be in trouble.
Further more trouble, yes.
Yes,
okay.
I don't feel the need of using Diamox. It is an aqueous suppressant. Once you make paracentesis, anyways the aqueous is coming out. So why is there any
Some people
role
do
of
have they give routinely Diamox, they give routinely mannitol, which I think is really absurd because Diamox has its own problems. Most of the Stevens Johnson, there is patients become so, side effects like loose motion and tingling numbness, and this is very problem. Anorexia is a very major problem. So you can't afford to do that pre-op. And secondly is that mannitol pre-op, is not at all mandatory, even in patients who are small eye. But in extremely small eye, then also up to 32, 33, I have not given mannitol. And I think Shugato has also done that. Up to 30, I have given no mannitol and nothing happens.
Thank you, sir. I think we had a very good discussion on the topic. Moving on to the next topic is with Dr. Shugato Pal, who is a very happy-go-lucky person, the editor right now of OSWB Journal. Tale of a Toric. Happy to unhappy to happy again. All over to you, Shugato.
I'm presenting this in front of you because you'll know when I present why I'm saying this. So it's a tale of a toric patient. So this is a 69-year-old male, 6/36 vision in the right eye, NS3 cataract, OCT normal, and is a glaucoma on 3 AGM, open angle, and IOP was very well controlled. So I decided to go ahead with normal phacoemulsification. So when the patient came in, obviously the patient is sad, poor vision, and I am happy. Okay, एक बंदा तो आया है जिसका हम ओटी में ले जा सकते, so I was happy. And this was the biometry. So 1.44 diopters. So I thought, okay, we'll go for toric, and the patient agreed. Toric calculation was done, and it was 12-degree placement. And I use an acral, no financial interest. I use the care group acral EC toric as recommended by the thing. So post-op day 2, and again in day 21, the result was 1.75 diopter cylinder at 95 degree. Vision is 6.6 minus 2. So no correction at all. So as a surgeon, I was very unhappy, but the patient was happy. From 6/36, his vision has increased to 6/6 minus 2. And he was very happy and didn't want any further intervention. So I discussed with him the possibility that there might be IOL rotation. I might have induced unusual SIA and wrong IOL or manufacturing issues. So IOL rotation you can make out in the slit lamp. So it was 12-degree, and you can see the placement. If we take this as 180, the placement is quite right. And what you can do for learners, you can narrow the beam of the slit lamp, and you can rotate the beam, and you can take the reading on the slit lamp, what the degree of the placement, and it was exactly 12-degree. So the IOL position was fine. Next is SIA, whether I have induced an unusual SIA. The SIA of this patient, if you can see, was 1.75 at 9 degree, and post-operation, it was -2 at 95, sorry, it was at 95, 175, and it was -2. So I have induced just 0.25 of cylinder post-operative, which was my surgical SIA as calculated by the biometry. So the only thing left was wrong IOL. So I suggested IOL exchange, which I am out of the nose. I need to do it quite regularly because quite often I damage the haptic of the IOL and exchange. So I thought of exchanging the IOL 21 days, but as the patient was happy, he didn't want to, he went away. Later, after 1 year, when he came back for the other eye, vision from 624, other eye went down to 636. He had again a toric IOL done, and post-op vision was 6/6 part, unaided, and left eye refraction, the second eye refraction was plano. So as a surgeon, I was very happy. But the patient, I thought would be happy, 6/6 unaided second eye, he was not. He was very unhappy, and he, from next 15 days, he kept calling me, আরে আমার ফার্স্ট আইটা চশমা পড়তে হচ্ছে এটাই লাগছে না I offered him surgery first time, but he refused because his left eye vision was poor, his right eye vision was good. He refused at that time, but now after the second eye, he wants something to be done for that eye. So patient realized basically the unaided vision difference between the two eyes and wanted the right eye astigmatism to be sorted out. So what can be done? So LRI I discussed, but that is quite unpredictable. Regression is there. LASIK, patients say, okay, I am happy if you pay for it, I couldn't. And the other option was I will exchange, but it is almost 1 year, some fibrosis was there, challenging. So I thought, I saw Sudipta's presentation and publication and Aurubda's surgery as well. So I thought, okay, let's try piggyback IVL. Salcofix is one of the options. And my luck was that it is also by Care Group. And I told Care Group that your IVL was wrong. So you have to give me the piggyback free of cost. Amulyajyoti gave me quite a bit of rebate for the surgery, and I didn't charge any surgical fees for this Salcofix insertion. This you can see is a lens with 4 haptic and is sit in the sulcus in front of the eye well. I'm not going in details, but it is a hydrophobic eye well, and it comes in the range for minus 15 to 15 degree plus 15 diopter, and it corrects a lot of cylinder as well, and comes in multifocal as well and multifocal toric. And these are some things which you have to give the BCVA, the K1, K2, actual endothelium, actual depth of the AC from the endothelium, then the white to white measurement, preferably by digital caliper, but we did it with the IVL master. So these are the few things which you have to provide, and the IVL company gives the thing, gives the calculation, and this was the IVL I implanted. This is a short video. So after the toric, এখানে অপশনটা আসছে না কেন ফরওয়ার্ড করে? So after the reference marking, সুদানিক এখানে ফরওয়ার্ড করার, ফাস্ট ফরওয়ার্ড করার এটা আসছে না। না,
আপনি পয়েন্টার দিয়ে দিয়েছেন বলে মনে হয় পয়েন্টারটা দেওয়া আছে না, এবার আসুন।
So after, once you form the AC, make sure you put the visco under the pupil and then loading the IVL. Loading the IVL is quite easy because it's a very small thin IVL, but you have to, there is a notch which you have to be careful. The notch in the leading haptic should be on the left, and when you are opening the lens, you have to make sure you can see the notch opening. Here you can see the notch is on the left. Here the notch is, you can see it's on the left, and so it's opening in quite right position. So once you have delivered the lens, the next thing you have to do is tucking the haptic under the iris. As you can see, it's a very large lens with the haptic extending. So you just press with one instrument, fold the haptic with the dialer, and just tuck it under the iris. Same thing goes for the other haptics as well. I'll just forward it. So you bend and reduce it and put it under the iris. This is a very minimally edited video, so you can see I'm struggling with the haptic here. Because the reason I'm not folding it. Once you try to fold it, it becomes a bit easier, but here also I struggle. But once you fold and place the second instrument behind it, you will be able to place the haptic under it. But there was little bit of struggle. I haven't edited the video. So once you have done this, just you can pull the iris slightly as well, and you can place it easily. Again, this was quite easy. Just pull the haptic, and you will be able to place the lens. So this was, as you have said, this was correction for the toric. So next thing you have to make sure you have positioned the lens. The pupil becomes small, but by manipulation I could see the position of the IVL. I'll just fast forward it. And you can see it's still slightly off axis. So I have to just dial the lens to bring it in the axis. And once it is done, it is done. The other thing, I'll just finish within a second. Only thing you have to do is to make sure you do a peripheral irectomy. Otherwise, this can be a problem. So that's the next thing. I think, yeah, I have done the irectomy now with the And once it is done, wound hydration, and you finish the case. So the unaided vision was 6 part, refraction was plano, IOP was normal, and 4 months follow-up, still there is no haze in the interference. So at last, happy surgeon, happy patient. Thank you.
But I think the care group was not very happy with you. You know why? Because you are using, you are not given the lens tucker. There's a special manipulator. You don't need the hook, because hook will always damage the
I'm
iris.
coming to that. It's not the hook is dialed. The tucker is well for the IP cell. With this,
Yes,
the
they
tucker
do give,
doesn't,
because
these haptics are very large.
Yeah, it does,
So you
it
have
does.
to fold the haptics, otherwise you will not be able
No.
to put it.
See, if you use the lens manipulator, it is a dull instrument. It is a blunt instrument. This is a sharp instrument, and there is already a lens inside.
Yeah.
Your pupil is not fully dilated. There is high chance you can go to the angle and hit it. Just let me finish.
Yes.
Because here, if you look at the haptics, they are very big ring haptics, oval, I would say. So you actually have to fold them on themselves to put them down. If you use a sharp instrument like a dialer, you might go and hit the iris at the angle. I have burnt my fingers, because I have a series of cases. So it is better to
there
use
an
a
easier
blunt.
way to
Yes, that's what I was going to say. So you have that lens just like an IPCL. You use a spatula on one hand. You pull the lens towards the other side while you are folding with the spatula, with the lens manipulator, this haptic, and then you let it go under the iris instead of using a hook. So next time, just try it out.
Yeah,
Try
I'll
out.
try that, but with the
This is
hook,
one
I think
part. This is
it's
one
much
part.
easier to pull and
Okay,
fold.
okay, that's individual, but that is how care groups advocates it. Number 2 is, once you have put in 2 haptics together, it is better to position the lens, because these lenses are not very easy to be manipulated. Once it is in the, I wouldn't say in the bag, it's in the sulcus. So because it's a hefty lens, it is better to position it if it is a toric one, and then better to put the last haptic in. This is one more tip that I would like to share. And the third thing is, be very, very careful when you are putting the haptics in, because many times I have burned my finger again, that is why I can share. It goes in the bag. If it goes in the bag, you are in the soup, because it is not meant to be put in the bag. It is to be on the bag in the sulcus. So these are the 3 things that I would like to add. You have done a great job. In fact, making a patient happy is all that we want. Yes, Sharon, please.
Thank you, Sudipta.
Yeah.
One thing I just...
No, not. No, sir, it depends on the anterior chamber depth and the position where you're going to put it. It's not mandatory. But for the first case, I too did a PI because I was frightened. But my case, the Sulcofix case is now 4 years. So she's 6'6" in both eyes. Yes, just 1 minute with Shayan.
Hydrophobic acrylic.
Yeah, both.
Hydrophobic.
Yeah. Sir.
Not in the bag.
Care group. No, the lens inside the bag was hydrophobic care group.
Yeah, that is the
toric,
thing, sir.
And this one is also hydrophobic.
Sugadada, একটা জিনিস। So far as I remember.
Hydrophobic.
Sir.
No. This one is hydrophilic. This is hydrophilic. Sulcofix is hydrophilic. Sulcofix is a hydrophilic lens.
Yes.
It is philic lens, and you have done the correct thing, hydrophobic over philic, which the literature says. But I have done a philic over philic because I did not have anything. It was during COVID times.
Separation which you have to ensure with ASOC.
Yes.
The same material touches with each
But
other,
it doesn't
we have
touch
to
if your AC depth is sufficient, and you have to do
But
your
there should be a
calculations before.
separation, and you have
Yes.
to ensure it with ASOCT. just
What
like
he
we
did
ensure
is the
what
ideal
we
one,
do.
because a hydrophilic over hydrophilic lens over a
have two
hydrophobic
material.
lens is what was reported for years in literature. But I did over philic and over a philic and multiple cases, and it's doing well.
Can
Yes,
you use a BHEX
can be done. It's in the
forceps
sulcus.
to tuck the haptics?
Because the lens has to be manipulated, and that is why it is made hydrophilic. All the companies make it hydrophilic. Even the Rayner company, they had hydrophilic.
দাদা আরেকটা
Dr. Shibashish Dash.
BX is a good forceps to use and tuck. But what Sudipta
Oh,
was
Amar
saying,
Nayak.
Sudipta, you are saying that it might go in the bag, but that is very
What will go in the bag?
the haptic.
Leading haptic, never. Leading haptic, leading haptic will never
Shubham,
go in the
put
bag,
biometric
and the
visa
company
also
itself also says it's
I
better
will
not to
master.
put in the bag.
700, no 500.
700.
700.
Okay, I think Salcofix has a lot of questions. Let us go on to the next.
Right. No.
না
Yeah.
মানে
Only
iron
one
mass
small
700 এরকম হওয়া উচিত না কারণ কষ্টের কারণে এটা চলে আসে তো
It is the manufacturing defect of the lens because SIA hasn't been.
So I hope
Yeah.
nobody's from care group here. So let's go on to the next topic, please, because we are waiting. Sir, I'll just come to you. For Dr. Arup Bose, sir. Dr. Arup Bose, sir, needs no introduction in Hooghly or in Kolkata, or I would say in India. I have been hearing this name since my school days when I was in Chuchro. He has enormous works, prolific surgeon, lots of teaching points, always we get from his videos, from his presentation. All over to you, Arupda, just allowing a very senior person to say one word. Please, sir.
No, one thing is, how do you do PI, Shugoto? Do you do with a vitrectomy cutter or with...
No, not advocated, sir. It manually correct hai.
Achha.
Sir, all over to you.
Oh, good morning, everybody. First of all, I must say that Sudipta, Pinaki, Subhasis, they have done an excellent job. This morning, you can see so many of us in this podium today. And thank you, Sudipta, for those nice words first. So, my topic today is to talk about EMB IOLs, which we are actually using it as in so many cases recently over the years. Now, if you look at the agenda, I want to, So there has been a change in the way we think and we decide on cataracts, and more patients are actually asking for near vision correction after having done an excellent distant vision correction over the years. So, but we must realize that managing presbyopia involves a compromise, and it needs a balance between a very good distance vision and dysphotopsias and loss of contrast that we get to see in multifocal IOLs. So we, even with EMBs and EDOFs, we need to know certain things so that we ultimately end up with happy patients. So these lenses are considered forgiving because their tolerance to residual refractive error is more than multifocal lenses. It has got a wide patient suitability. It's more suitable in borderline cases with corneal opacities, a lot of other problems. It gives rise to minimum dysphotopsias. That there is reduced sensitivity to higher order aberrations, and they have got less impact on pupillary size. I call it less impact. I don't say there is no impact. If you look at the intraocular lenses that are available for a desired EDOF, we actually need these sort of extended focal extension of the focus, but we don't actually get it unless and until we put in a small aperture EDOF, which is the real true extended monovision lenses. When you are using aberration corrected IOLs, we are actually inducing some amount of dysphotopsias, and with diffractive, we all know there is a lot of dysphotopsias which are actually induced. The real EDOF is a small aperture EDOF that we get to see with IC8. But these lenses have got its own problem because they restricts the amount of field that we get. There are diffractive EDOFs, many of them in the market. Many of them are actually coming, newer lenses, but they are diffractive. All diffractive lenses have got dysphotopsias. You need to know and keep it in mind. And the enhanced monovision lenses, like the lenses that we get, Eyehance, this Reynolds lenses, Hoya lenses, and isopure lenses, they are basically, they play with spherical aberrations at the center. So two types of EDOFs that we actually get, not EDOFs, EMB lenses that we get in the market today are either a positive spherical aberration at the center, like Rayner EMB lenses, or a negative spherical aberration at the center, like Ihans, Isopure, or Vivinex Impress lenses. These are the 4 lenses which are actually available, standard lenses available with us. And in my experience of, it's not 284, it's 184 eyes, I get basically about 0.75 diopters of near vision correction. And if I do a bit of mini mono, that is non-dominant eye, I leave behind 0.5 diopters on a myopic side, I get a fairly good near vision. And I ask the patient to use more light for reading and not to use glasses unless and until it's absolutely required. If they make the habit of not using glasses regularly, they actually over a period of 6 weeks or 2 months, they get back some amount of near vision because of the neural adaptation. But no lunch is actually free. Now, the moment you increase the depth of focus, you know that you are compromising on the contrast sensitivity of the lens. Now, to give you an example, this is a contrast sensitive MTA value. This is an eye test picture of a patient who has undergone a toric lens implantation. It's a monofocal lens, and as you can see, this patient has got an MTF value post-operative which is as good as 72.5%. This is a patient named some S.R. Das, and the same patient's wife whom I have implanted the same branded lens, but an EMB lens had a MTA value which is 414, that is 41.4%. That means it reduces the modular transfer function or contrast sensitivity by about 40%, by about more than 30%. Even if we compare between the Technis and the Ihans lens, as you can see in the top, there is hardly any aberration in the center. Of course, there is very small amount of positive aberration. But in the lower part, you can see that Ihans lens has got a central zone which is actually negative spherical aberration lenses. That means you are inducing negative spherical aberration. And if you compare between a monofocal aspheric lens, that is how the central part looks. If you see the wavefront aberrations at the center, and if you compare with an EMB lens, this is a positive EMB lens. As you can see, the central part has got a red ring, which indicates that that particular portion has got a higher K value. And this also indicates that this patient, if the pupil becomes too small, will have a myopic shift of vision. So, are all patients are good candidates for EMB lenses? Patients who have already got loss of contrast because of drusen or macular degenerations, patients who have got a diabetic macular edema, patients who have got subnormal optic nerve functions, as in glaucoma and optic nerve disease, patients who has got an ERM, and patients who are already compromised retinal surface because of dystrophies, they are actually not good candidates because they already have loss of contrast. And if you put in a lens which has got reduction in contrast post-operatively, these patients are not going to do well. And two more patients, type of patients you should always avoid is a patient who has got a very small pupil. A pupil which is less than 2 millimeter. These lenses are going to be very unpredictable, and as these lenses, particularly if the lens is decentered by more than 0.5 millimeters, they are not going to do well with these lenses. Now, there is enough number of evidence and studies to show that pupillary size significantly influence the visual function of these EMB lenses because they rely on the aspheric profile that interact with the natural positive spherical aberration of the cornea. And pupil size determines how much of the IOL's peripheral optics are engaged. Now, any pupil which is less than 2.5 millimeters, mostly central zone is used. The effect of enhanced optics is limited. And if the pupillary size is between 2.5 to 4.5, these are the patients who will have optimal sharpness and extended intermittent vision. And patients with a large pupil, lot of peripheral portion of the optics will be engaged, and these patients will also have reduced contrast. Now, this is a study done by Vivinex Hoya group, which showed that after 12 to 14 months, pupil size made a lot of difference. As you can see, the last one, when the pupil size is 4.5 millimeters in a negative spherical aspheric lens, you get a correction of 1.5, or about 1.4 lines. As compared to a pupil which is 3.5, you get a correction of only 1.2 lines. So the correction increases if it's a negative spherical aberration, if the pupil is slightly larger, but not beyond 5 millimeters. Even the axial length has got an impact. This is an eye. If the axial length is more than 24 millimeters, these negative aspheric lenses do better as compared to axial length which is less than 23 millimeters. Even angle kappa has got a role to play. These angle kappas are actually responsible for slight decentration of the lens, and they can affect the tolerance and higher order aberrations even with EMB lenses. If the angle kappa is more than 0.5, angle alpha is more than 0.5, these patients are not going to do well. This is a patient who had came and actually being counseled for multifocal lens. If you see this patient after having the eye test, I could make out that this patient has got a total higher order aberration of 0.867. Anything above 0.3 is not good. Angle alpha of 0.712, which again indicates this is not good case for even EMB lenses. This is how I think it's not very clear, no point pointing it. But the distribution of angle alpha, you should always know. 20% of our patients has got an angle alpha of less than 0.3 millimeters, which is actually optimal. About 51% of the patient has got an angle alpha between 0.3 to 0.5, which is borderline. And 29% of our normal population has got an angle alpha of more than 29, which is actually dangerous. And these are the patients where you should put in a monofocal lens and a multifocal. So what are the cases where I avoid putting these lenses? Number one is an irregular or a diseased cornea like keratoconus, posterior ectasia, some amount of scarring. I avoid this patient who has got a significant ocular surface defect. I avoid these patients in patients with macular pathologies like, as I have shown, that macular degeneration, epiretinal membrane, diabetic macular edema. I avoid in patients with glaucoma, and I avoid in monoocular patients who has got one-eyed patients, because in those cases we want the maximum contrast, and we do not want those patients to actually get less vision even in low lighting condition. Thank you very much. Thank you for your patient hearing.
Thank you, Dr. Arup sir. As usual, I think we have lots of take-home messages from his presentation. I would request Dr. Shamul Pandey sir, our chairperson, to share his experience with such lenses.
Actually, I have got less or no experience because I am using only monofocal lenses.
Sir,
it is actually a good idea. After implanting a lot of multifocals and EMB lenses, we still feel that if you have to get yourself operated for cataract, always opt for a monofocal.
I have more or less 20 multifocal lenses I have implanted. The first lens which I have implanted is a spinster, and she is working in the school English medium. She is extremely happy. But after that, I implanted that multifocal lens in a station master who was not so happy. After that, I implanted the multifocal lens in a healthcare assistant. She was also not so much happy because I had to give the correction over the multifocal lenses for the near work. So this is my experience. My surgery is not so much up to the mark. For that reason, I have taken out this thing. Now I am explaining everything, and that you have to, because I am wearing the glasses. Most of the persons are wearing the glasses. So I am doing only monofocal lenses.
Thank you, sir. But I think it's a.
Can I? Hey, Sudipta.
All of you
Arup,
agree the correct thing. That,
just a minute. I have a question for you. You have not specified any company's name, any model name in your presentation. It was a generalized. Nowadays we have got EMV lenses which are very, very less inexpensive, as low as 4,000 to 7,000, 8,000, 9,000, that's it. And because of this, we have now shifted, especially myself have shifted to more of EMV lenses than the monofocal lenses. And these EMV lenses, I am using it right and left in cases with glaucoma, in cases with drusen's, not with advanced macular degeneration. But in all this, I don't think, I may be wrong, that there is a difference in multifocal lenses, there is a light distribution, where for the central near vision and distant vision, there is a light distribution and intermediate. But here, there is not so much of light distribution. Because of that, if you use it in all those cases where you have shown that we should not use a multifocal, you can use an EDOF lenses. I don't want to name, but I would like to name, like one is AdTech Comfort. It's an excellent lens. You use it in the patient with low budget also, and they have excellent vision. Other imported lenses like Hoya and all, they have got very good lenses, and these are all come below the 9,000, 10,000 below that. So when you are thinking of putting a Panoptics, VVT or POC or something like that, the budget goes very high. But these lenses they are very, very forgiving. For all cases, if you do it, even in one-eyed, I have done in one-eyed patient. That was one person I have done in VVT, another I have done this Hoya, and he's very happy. And if you do it in both eyes, they don't require glasses for 95% of their job, and they are very forgiving. That's what I feel.
No, there are two things I'd like to. I've already discussed, but I want to explain. Now you get to see a lot of VVT lenses have got refractive surprises. You check the central pupillary size in photopic conditions, you'll see that they have got a very small pupillary size. Because both VVT and even Comfort has got a modification at the center. Any modification at the central part of the lens, optics, will ultimately cause some amount of reduction in contrast sensitivity in low lighting conditions. It has to, because it's basically basically a balance between the depth of focus and the MTF. It can never occur that the vision for distance is 100% and vision for near is 20 or 30%. Because it has to cut from the distant vision to give you a near vision.
That's what I'm saying. In cases,
vision is always the same.
In case of VVT, you will see there is a 2 millimeter hump. Less than 2, I think, there's a hump. But in Comfort and in Hoya Impress, there is no hump. And I think their ranges, the size of that is slightly larger. That is because the surprises are much lenses in
but in that case, you'll have to keep in mind the spherical aberration of the cornea. Now, suppose a patient has got a spherical aberration of the cornea of 0.1 millimeter, because we always want to leave behind 1.5 to 1.17 microns of positive spherical aberration in the whole optical system to get at least a depth of focus of 0.5 diopters. Now, if you don't leave it, if a patient has got a spherical aberration of say 0.2 and you put in a lens which has got a central spherical aberration, be it in the positive zone of 2, that means the patient is not going to have any depth of focus. Ultimately, it will be left behind as a monofocal lens, with a monofocal aspheric lens. So there are a lot of things. The moment you start doing an eye test in these patients, you'll get to see that why the results are so unpredictable with EMB and EDOF lenses. Some patients do actually very well. They need hardly 1.25 diopter reading, and many of the patients are actually requiring more than 1.75 or 2 diopters for reading. because there are lot of things in the optical this thing, system which actually affects the results of these lenses.
Thank you, Arupta. I think we are very now learned about all these advancements as always in your talk. So I am sure there will be many other points to discuss, but we should move on now. The next speaker is none other than our chairperson, scientific committee, who is present, omnipresent. She is smiling everywhere, and she is multi-talented. She is going to talk about amiss rent during aisle insertion. So she is so honest even in her skillful and so brilliant hand, she still gets the complication and she is ready to show us that. Thank you, Sip, the audios.
Yeah. Thank you, Binakida, for that introduction. Yes, it is the blessings of all here that make me smile today. So, a miss PC rent after an IWell. There is an audio, please, if you can. একটু music আছে দেওয়া আছে আচ্ছা so this was a lady, a high diabetic patient with no music. Why দেওয়া আছে this was a music কিন্তু আসছে না pretty hard cataract, high diabetic, controlled poorly. Finally I took বলেছি অনেকবার anyway so নেই আসছে না so I went on with staining the capsule as all of us do and finally came up with a rexus slightly bigger I would say because these cataracts was not looking as soft as it is so everything was going okay. I was being a bit careful because it was not fully dilated. Yes, as you can see, it was quite hard. And you can see the shin of the nucleus, that metallic shin which tells us. But my chopping was not, I would say it was fairly good. Acceptable chopping into multiple pieces, although there was a central leathery cataract. And there, the center part, which I've separated, I lifted the center part a bit because it was very difficult and not getting detached, but started eating from the periphery. And once it was debulked, I was using high density viscoelastics as well. As you can see, it's very leathery. It's not very easy to go. All this is actually the prelude to what actually happened. I was careful, was probably using maximum of my attention, and finally, I thought I had fared well. I was at the end of my nucleus removal and with the intact PC as I thought. So where is the rent? There's no rent, nothing. It's just like that. Is there a rent? Shigato, can you see that rent? No. So there goes my IWell and this patient moved immediately and IWell went shooting in. But okay, fine. So what? It's a formed AC. I tried dialing it, washing it, and there is the rent. Basically, IWell could not be placed properly. And then is what made me realize somewhere I have done something wrong or something was there which I did not notice. Tried dialing it, repositioning, finally realized there was some subluxation somewhere or a rent somewhere which went amiss. And I had to dial it out in the anterior chamber because there was already some amount of vitreous which was stacked in the haptic. And the next steps were quite usual, staining with triamcinolone, then trying to do a bit of vitrectomy to release the haptics from the vitreous strands. Now, only thing for me was that I did not know where the rent was. I could not pick up. So it was a blind procedure. But still, since the IWell was there, it was a protection somehow. Next was to take out this IWell, which I used a Rodic method, cutting it till the 2/3 and then dialing the whole of the whole of the lens out. Again checked. And when I was quite sure the vitreous was not there, I tried to look at my anterior capsule margin. Well, it was good, but I couldn't use a single piece IOL, which was planned. So went for the multi-piece IOL. And then that was dialed in the sulcus. And the day was saved. So that is my case of a miss PC rent during IOL insertion. Thank you for patient hearing.
Thank you, Sudipta, showing us the beautiful videos where the things can go wrong. But I think we could always see that in the main incision, the extension of the rexis, which happened near the main incision side.
No,
are you,
no,
are you are you with me? Can
No,
you
no,
can
no,
anybody?
no.
I thought in the main incision just there the
This is
extension of the
edited,
rexis.
Pinakita. This is highly edited because it's just 4 minutes. And definitely I couldn't make it within 4 minutes.
Nobody
I
could
took
see
more time.
anything.
There
Could
was
you
no-
go back? Is it possible to go back?
Yes, of course,
and
it's
just
possible
freeze
to
the-
go back. I can show you the original one also, but there was no extension.
No, I thought there's an
Here,
extension
here,
of the
here, you
rexis.
can see this. Here it
Yeah,
is.
where just near the incision, the extension.
No, no, no.
No, just go back, go back, go back, go back.
I'm showing you the rexis at the margin.
No. Listen. There is the flap of the rexis there. It's not there.
No, it is there. I just went off.
Actually,
Any one.
extension happened here. You go back, you could see. Yeah. Go
Just
back.
before this,
Further
yes, I'm
back,
going
yeah.
back, going back. Where do you want to see this?
Here. Just right here, actually, the extension. You go
Cortex.
behind.
Cortex, okay, cortex.
Go behind.
Before the IOL, right?
Yeah, before that.
Can you,
Before
I
the
don't have a
IOL.
pointer, 1 second, I don't have a pointer. If you can make out, that is the rexis margin. Can you see the rexis margin? If you can make out. Can you see the rexis margin?
It's-
Yeah. No, sir, here I have shown there.
You go back.
And I'll show you the 3 o'clock position as well. এটাই এই ভিডিওটা আমাকে মাথা খারাপ করেছিল because I could not find out. I'll show you this part. Sir, here. Somnath sir. দেখতে পাচ্ছেন 3 o'clock? There is the 3 o'clock. I was actually looking. I looked throughout. My anterior capsule was
You
absolutely...
go further back.
স্যার এটা না পুরোটা পাবেন না ভিডিওটা দেখতে পাবেন কারণ আই অ্যাকচুয়ালি ফাউন্ড আউট মাই হোল অ্যান্টিরিয়র ক্যাপসুল বিফোর আই ইনসার্টেড দ্য আইওয়ে
Okay. Anyway,
it's okay. It's a
Anybody-
rent of the
any of the
posterior
panelists
capsule.
you want to make any point?
This is excellently managed. This is a very good thing that you have explanted the single. Many surgeons will put that single piece in the sulcus only. That is a grave mistake. You have explanted. You have taken the pain to explant the IOL, which is not easy. It is very painful to the patient. Patient complains next day. Doctor Babu, amar kintu prochondo legeche. But you have done what is best for the patient. You have explanted the IOL and you have put in a single piece IOL. Otherwise, the patient would have had uveitis for a long time.
Thank you, Siddhartha, for your words.
So, Sudipta, what next? After you have done an excellent surgery, managed it so well, how did you counsel your patient?
Yes, this was very important. Unfortunately, Sugata will now come up because I really had to, I was crying outside because this was my mashi. So anyway, I had to be this, and one more thing I will tell you. This was being seen by my uncle and my husband while I was operating. This was in because it was getting transmitted to the patient sitting area, so everybody was seeing. I had little bit to explain because one thing was good that they saw what I did, that I took out one IOL. This was the first. If it was a patient, of course, this is for patients. First of all, it is always best to show your surgery. If you record, you might not be live. It's good to record. It is always best to be honest to the patient. Nothing like that, because patient accepts if you are honest to them that I could not, there was an accident, I have tried my best, I have not been able, this was single piece IOL which was costlier, not been able to give this IOL, but at that moment I thought that this patient could be given an IOL and I have given what I have done my best. So that is how I counsel, because it's not the only single rent that I have. Definitely in my 24 plus years of practice, I have rents, but even if not rent, even if whatever you do, I have had a very bad experience of having hyphema in a patient of femto laser cataract surgery. That was while I was putting the IOL, patient moved, everything went well. Patient party was watching, this was in BBI Foundation long back. Patient party was watching. I washed it off. I waited, put in air, waited for some time for tamponade. The whole thing subside. A bit of the clot I allowed because I did not want to pull it out. But I was honest. I just put my hands up and I said, yes, this was there. Accident. What is in my teaching? I think that's the best way. I have done my best for you. Now it is up to you to accept me, or you can go to further centers or find out. So
On that note, I had a similar situation, but that is back in NHS while working in UK. I was doing a phaco. It was an uncooperative patient. Suddenly, when I was removing the fourth quadrant, the patient suddenly jerked. She suddenly just tried to move her head forward. Suddenly jerked, and whole of the tip with the phaco with the fragment gone into the vitreous. So it happened. It can happen to anybody.
And Arup sir, one thing, one of my seniors have just told me that if you keep audit of your cases, if you can have some video records of cases that you have done and patients has done well regarding the IOL or the complication, and then you have a backup to show to the patient or to the court or whatever, that these things are very natural. I have managed this patient, and so it is not that I am an inexperienced surgeon or I have done something which are out of the blue. So that is, once a senior has suggested this to me, and I think that's very good. You can do an audit of your cases, keep a record backup.
So Sudipta, what did you do for your Mashi? Did you exchange that IOL and put a multipiece in the sulcus? This case, did you do that?
Yeah, it is there.
So you
She's
had
doing
to...
well by God's grace.
And another thing, similarly on this note, I had once, just with a visco, I plastered the posterior capsule. I thought it can never happen, it will come out. But believe me, I filled it up. That time I was not using the BSS to put the lens in. I filled it up, and it was I think hydrophobic but a thicker lens. And just while pushing, the intraocular pressure gone so high because the main wound was blocked by the cartridge. And the visco itself, it got so much, it just busted the posterior capsule. So it can happen.
Thank you so much.
Okay. Thank you, Sudipta. Our next speaker is very young, dynamic person, Sivasis, who is going to talk about a subluxated cataract managed with CTR.
Good morning, everyone. So, today I'll be presenting just a small 4 minutes case on a subluxated case that I encountered. Initially, preoperatively, I did not suspect much of the subluxation. I missed some of the warning signs. So, as you can see, the case started off fairly okay, unsuspecting. But if you could see that on the just after we have removed staining the anterior capsule, we have made the main incision, filling up the AC with visco. We see here there are some puckering on this edge of the bag's rim. So after completion of the rexis, once we do the hydrodissection, it was a gentle hydrodissection done, just one fluid wave which went in. Now, after the hydrodissection is done, now we will be able to appreciate the subluxation. You can see on this side, there is a proper subluxation, there is a big gap between the bag and the ear. So, initially started to do with the phaco, I just wanted to get a feel of how stable the bag was. but at this position it would be better to secure the bag with a capsular hook. But at this stage, we felt that the bag was not very stable to go ahead with the phaco. So the better decision was to try to secure the bag with a capsular tension ring with some viscoelastic under the capsular rim. We'll try to put a capsular tension ring. Once we get a capsular tension ring in the bag, the whole thing becomes very stable. There's a lot of, we are at peace that, okay, the bag is not, the bag won't move so much during our phaco surgery. And once we have the trailing part of the CTR in the bag, then it becomes like a more of like a routine phaco surgery. We'll try to keep all the pieces, we'll try to break into smaller pieces so that the movements, we'll try to reduce our movements and handling, try to break the pieces into as smaller bits as possible and emulsify the pieces inside the bag. So once that is done, the next challenge what comes in when we have a CTR in place is the irrigation aspiration of the cortical matter is not very smooth as it would have been without a CTR. So sometimes we see in this area, I think the pointer is not visible. Sometimes in this in the superior area, we see that the cortex is not coming. You just leave the portion which is not coming. Don't try to pull very aggressively. If that portion of the cortex is not coming, just put in the lens. Once the lens is there inside the bag along with the CTR, it gives a little more additional support. Then we can slowly go in once the lens is dialed inside the bag. Once we wash away the visco, during that time, we can gently pull the remnant of the cortical matter that was there, slowly pull out the remnant of the cortical matter that was there, and then at the end, just to be sure that there is no vitreous that has prolapsed through the subluxation part, you just put a little bit of diluted triamcinolone acetonide, wash away with our normal BSS, and once we have secured the ports, so the patient with the subluxation did fairly well and the lens is well centered, and on the post-op day also the patient did fairly good. Thank you.
Thank you, Subhasis. That's a brilliant surgery you did. You managed very well with that amount of subluxation. And before I ask you something, can I just pass it to the panelists? If you have any comment to make with this surgery?
I think it was managed very well, and you have a lot of courage to just put CTR, and with that much of dialysis, I would have been afraid. I would have put capsular hooks and done
while doing that is why when while doing the phaco, we get a feel that how much the bag is moving. If the bag, while doing phaco, we see, because I went in with the Phaco Pro first, if the bag, I felt that the movement was not much. It was not the like the rexis is not shifting totally in one side. The movement was not very much. So in this kind of low grade movements, a CTR will do. But if the bag thing is going this side, then maybe a then a Sioni ring, we would have to suture the Sioni ring to that side. But with because the movement was less, I felt the CTR would do good.
You don't need Sioni ring for this dialysis. But during phacoemulsification, a lot of granular stress happens. Putting a capsular hook is safer.
Yes.
But what you did was absolutely fine. For an experienced surgeon, I think this is okay. But for a beginner who is just starting off, I think.
But the point was, I would like to say, for any subluxated cases or in cases where is no subluxation, but you feel that there is some amount of zonular weakness. In many cataract cases, we see all the cataract cases are not perfect. Like while doing rexis with slight movement, we should try to reduce our movements inside as much as possible. Make into 8-10 pieces, make smaller pieces and then eat away 1 pieces. Don't try to manipulate too much. Minimum manipulation will lead to lesser of zonular loss.
That's very nice bit of surgery. I just want to ask you, while editing, how much faster it was? 8 times, 10 times?
No, this was in middle portions it was 2 times, and in the redundant portion it was 4 times. The total surgery time was 16 minutes 16 minutes, 5 seconds.
It looked very fast when you were moving that. I thought it's very much.
Now, this subluxation can occur because of two reasons, either because of a trauma or is spontaneous. So anything which is occurring spontaneous has got a risk of this subluxation, the lens getting dislocated inside. So do you actually, differentiate the way you handle these cases, whether it's a traumatic or a non-traumatic subluxation?
Non-traumatic subluxations, like in patients who are having malfunctions or something. So in those cases, the chances of the thing progressing, we need to be a little more careful in those cases. We need to secure the bag more properly, because in those cases, sometimes later on the bag can get dislocated again more. But in cases of traumatic cases, I think with minimal zonular loss, we can manage with CTR.
So when you have noted that there is a possibility of this subluxation, whether you are going to modify your rexis size or not?
When there is a subluxation, yes, we do modify our rexis sizes. In these
How?
cases, I would prefer to have a little larger the rexis than I would normally do.
So in this situation, your rexis is little bit
On
the
the
smaller one.
smaller
So
side.
you have to extend,
This
increase your
rexis
size.
was almost like what I do routinely. But while doing the rexis, I did not I did not notice the subluxation that much. There was some amount of some puckering on the side, but the proper subluxation I noted after I did hydro and I put visco. So if I would have noted the subluxation before, I would have done a bigger rexis. That would have also reduced my handling inside.
And also that can ease your cortical matter, leftover cortical matter removal.
Yes.
Okay.
You definitely did right thing, leaving that bit of cortical matter there before putting the lens in, rather than trying it and pulling it more. That's that scaffold and that releases a bit more. Thank you. Any of the chairpersons, do you want to make any comments on that?
Excellent surgery, I said.
Okay. Thank you. Anybody? Any questions? No. Okay. We move on for our next topic. And next speaker is another stalwart from our Hooghly districts. Everybody knows him very well. Apart from ophthalmology, he is also a very, very, very good painter. He has probably not getting any time, having his third or fourth centers opening up. Otherwise, previously, every month there was in a Facebook his painting. We were amazed.
I'll give you. Let me find out some time.
Okay. He's a singer. Oh, I haven't had the chance to listen to his
Anyways,
songs. Okay.
Thank you, everybody, for coming on a rainy day and a Sunday. And I am from Hooghly district, so I welcome you all, those who have come from all the way from other districts and Kolkata. So my presentation is very interesting case presentation. Recently, about 3-4 months, I had this patient, 69-year-old male, underwent uncomplicated cataract surgery, absolutely uncomplicated. So I didn't keep the record of the surgery. Usually I keep a record all, but which are needed I do it. So I will not be able to show you the per-operative, the initial one. So he came back after initial refraction in 3 weeks time, only after 3 weeks with DOV, diminution of vision in the same eye. So no intraoperative zonular, capsulozonular complications. People were slightly small, but not that significant to mention. So phacoemulsification with implantation of the hydrophobic acrylic monofocal aspheric IOL in right eye, and I did the pseudophakia in the left eye, and unfortunately the patient had a refractive amblyopia in that eye. That is done about 4 or 5 years back. So he is a known case of systemic illness, known case of ischemic heart disease, and he has undergone CABG and recently diagnosed with interstitial lung disease. He was having chronic cough, so his pulmonologist has given a query of interstitial lung disease, not very florid. And this is just a brief history. So on pre-op 7 days, as we do a refraction, and it was 6/9 with 1.25 diameter cylinder, and left eye was 636, at which was the refractive amblyopia, and accordingly the near vision. So complaint of blurred vision 3 weeks after cataract surgery. Right eye came down to on third week is 18 and PCIOL with anterior capsular phimosis. Left eye pseudophakic, no capsular contraction even after 4 to 5 years. So this is the patient. This is the first 3 weeks picture, the first one. And if you keep the patient undilated, you see the whole capsule is opaque. And on 5th week, this is the picture. There is absolute closure of the capsular axis. Complete closure. Just a pinpoint opening is there. But there was no capsulozonular problem during surgery. So I was really perplexed what to do. So I did a YAG. This is a, you can, if you think this is a decentration, not that. The zonules are there. It is the capsule, lens edge is showing. So this capsular bag is central. There is no pulling. It is a centripetal contraction of the, of this capsular axis opening. Absolutely centripetal. It is on the center. So I did a YAG. Vision improved up to 618. It was finger counting and 618. But patient was not happy definitely. He was seeing 69. So I took the patient for surgically removal of the, I just first initially snipped off those YAG openings slightly large, and then I tried to, quadrant wise, I tried to cut open the capsular, this fibrotic capsule. And I saw a few videos, and there are surgeons who have done it, and they can, some surgeons can do it in a ring-wise fashion, but I couldn't do it. I was literally scared that what happens. I could enlarge the opening.
Didn't you think about trying it with a vitrector cutter? When
No,
it is so tough?
I didn't try. I had a micro scissor and a micro forceps. So with the forceps, I can hold it and remove it, and I did it. You can do it with a vitrector. In pediatric cases, a lot of fibrotic capsule, we do it with a vitrector. But I took out these pieces, and I'll show you. With the micro forceps, and I didn't open up the main wound, just 3 side port wounds, 1 millimeter I did, so that I can use both the instruments, whichever is necessary from which port, just to give a support. So I took out this small fragment and kept it, and this side also I could make slightly larger with a, but it is very, very fibrotic. That is the thing. Within 3 to 5 weeks, this is the condition of the capsule. We get a lot of fibrosis in long term. There are naturally these LE cells, in the discussion I'll tell you. So this is, I took this out, and so post-operative after release, 21 days, this was the picture of the right eye, and I wanted to show you in retroillumination there is no PCO. It is only the anterior capsular contraction. So I sent this tissue to histopath, and with a normal capsule. So in that thin capsular histopathology, you see the beautifully lined LE cells, the lens epithelial cells. It's a normal capsular axis remnant. I sent it, and this was the piece I took out and did a histopathology. You can see there are a lot of fibroblasts. Within 3 weeks, there is fibroblast. So metaplasia is the main pathology. The lens epithelial cells, acutely, there is some reason they went for a metaplastic changes of the fibrous metaplasia. So metaplasia is, I defined as sometimes we forget, that is when a differentiated or mature cell type in a tissue replaced by another kind of differentiated cell type in the same tissue. Like squamous metaplasia in the lung, you get because of the smoking, or there is some sharp tooth in your this thing, you get a epithelial lining change into metaplasia. That is the squamous. There is some irritant. But what is the irritant in this case, nobody knows. So why it happened? I'll just tell you. And these are the fibroblasts. I've given a photograph because you can see, if there's no pointer, you can see these are the fibroblasts.
Pointer nahi?
These are the fibroblasts.
Pointer.
And these are the fibroblasts. And here the fibroblasts. Pointer থাকলে ভালো হতো। So, left eye, I did 4 years back. This is there was no capsular contraction. So this is not a systemic problem in that. Why it happened, I don't know. So if I go into a discussion that anterior capsular contraction syndrome is an exaggerated fibrosis of the anterior capsule following uncomplicated cataract surgery. I have given 2 references, you can go through that. The normal residual Ellie cells in a capsular bag are replaced by fibroblasts. Actually, if I discuss slightly bit, that immediately after cataract surgery, when the intact lens is there, the epithelial cells gets all the biochemical and the nutrition from the lens. The moment you take out the lens epithelial cells are in a different environment. So how they behave, you don't know. So there are 2 types of Ellie cells actually, equatorial and anterior capsular. The equatorial cells get into those bladder cells and you get the PCO. And anterior capsular cells, they change into fibroblasts. This is a normal happening. So there is an exaggerated response in this case within 3 weeks. Why it happened, I don't know. So ACS leads to centripetal constriction of the capsular axis and the capsular bag diameter. Significant vision loss occurs due to central capsular opacification. As I showed you, they're absolutely pinpoint. There's nothing, no opening. And late complications like pseudophacodonesis, IVL tilt, decentration may follow if you don't treat it. So there will be further contraction and zonules will get loose and you can get this thing. So risk factor, pre-existing, pseudoexfoliation, zonular dehiscence, chronic intraocular inflammation, diabetes, these are the risk factors pre-existing. It was not there in this case. I don't know whether it is associated something with the ILD, interstitial lung disease, any immunological changes happening in his body, I don't know. So small capsular axis is another reason where a lot of Ellie cells are there, you left inside the bag, inside the anterior capsule and that can contract. And IVL material design. This is also an important, so a lot of researches are going on this only, how to prevent this Ellie cell proliferation. So in acrylic IVLs, incidence of SCCS is significantly higher with the hydrophilic compared to hydrophobic IVLs. So Nd:YAG laser capsulotomy can be done to recover visual acuity, but it is slightly small in this case, and in case of thick anterior capsule, you have to cut it. So conclusion, our patient presented with the anterior capsular phimosis within 3 weeks of uncomplicated cataract surgery, despite having 5 to 5.5 millimeter capsular axis, no predisposing ocular condition, fellow eye operated 4 years ago, no postoperative complication. So ACCS is a rare complication of cataract surgery and only few case reports are published following uncomplicated phacoemulsification. So these are few references. You can go through that if you want. I can give you the references, but this is very interesting case. Thank you.
Thank you.
Would you suggest doing anterior capsular polishing to prevent this condition?
See, you please read one article of Dr. Samuel Muscat. He has written a beautiful article on dead bag syndrome. Dead bag syndrome. After cataract surgery, the whole capsular bag and the lens has dropped. Because as you remove these Ellie cells, this capsular fibrosis doesn't occur, so there is no holding of the bag, and sometimes posterior capsule becomes very thin and diaphanous because of the lack of nutrition into that posterior capsule, and it gets ruptured. I think Siddhartha Ghosh has presented 2-3 cases of capsular this dead bag syndrome. This is a new entity, so whether you polish it very meticulously and remove all the Ellie cells is a query now.
I think there is
It's
something
controversial.
with the lens material as well. Like if you consider going through the Johnson lenses, you put say 30, 20 years ago or 15 years ago, they still comes with a very clear anterior capsule, posterior capsule. Whereas even in alcohol lenses,
Yes, yes,
I
I agree.
found alcohol lenses also there is a always within a month it is get adhered with the anterior lens surface and there's started proliferation.
That's why I told you that the moment you remove the lens matter from a capsular bag, the early cells start behaving differently because of the nutritional environment, because of the chemical component of the lens, or the size of the lens, or stretching of the bag, whatever it may be the reason. So early cells start behaving differently after cataract surgery. So what will happen? Nobody knows. PCO occurs, we remove it with the cataract. But this kind of cases are very rare. But it has occurred with me, so I am presenting it. Thank you.
Now we are very much running late. I think we should continue asking in the questions later on after let the other speaker finish and then we
And
can talk. There are so many other questions.
Pradeep,
One question.
Just 1 second. I had some cases of capsular fibrosis. RP was there in 2 cases, retinitis pigmentosa. Or did this patient had
All secondary cause I mentioned.
this patient didn't have anything of that?
Nothing.
Very interesting case. Very interesting
That's
case.
why I am presenting. Had it been a secondary cause, there is not important. But no secondary cause with acute anterior capsular contracture. That is it.
We can discuss the other things during the lunch. And our next speaker is none other than the savior, the Devdulal the savior. Everybody knows in Hooghly district, anything problems with posterior segment, Devdulal is there. Always say, yes sir, yes sir. I never heard him saying no to anyone. Devdulal, are you hearing that? So you are the savior of all the ophthalmologists in Hooghly district. Okay, now we are going to learn what we need to do in case we get a drop nucleus.
Thank you so much, Pinakida. That was simply overwhelming, and thank you so much. I am the sort of the odd man out here because I am primarily a VR surgeon and not a cataract surgeon per se. But as time went on, I had to do a lot of cataract surgeries, mostly with difficult cases and post VR cases, which were sort of my cup of tea, sort of. So when Pinakida actually asked me to present this, when nucleus drops, stop, stabilize and send. It's very difficult actually to predict how a surgery went on a particular day, and as you can see, these are different images of dropped nucleus or a drop happening. So it's very rare that a person will be able to send me something like this. Nicely done, lens placed in the bag, optic capture and everything. But most of it will be, a situation where there will be some cortex, some, nuclear material here and there, and the cornea might not be okay, because this is a situation all of us are scared of. So, there's no shame in accepting that this is something that happens, and happens to all of us, including me, after so many years of ear surgery and, cataract surgery as well. So, these, very important to realize early and by the primary surgeon, and it is critical to minimize further damage and optimize outcomes. So like we've been discussing since morning, there are various conditions where which have a higher risk of nuclear drops, such as pseudo-exfoliation syndrome, advanced intumescent cataracts, traumatic cataracts, and previous vitrectomy or glaucoma procedures being done in the patient, shallow AC, etc. Advanced stages. Another important, patient. The advanced stage category, I think, is very important today because we have a geriatric population that is ever growing, thanks to our good management of various diseases that come with age, and so we have more of these very elderly patients coming in for surgery, and we can have issues. So it's very important to realize when things are happening. For example, this is a surgery being done. So you can see this is adequate. I would say this amount of hydrodissection is adequate. Now look what the surgeon is doing. Again, going in with the hydrodissector, there's the snap sign. So one has to be careful. One has to understand this is again an elderly patient. You can see the pupil is not dilating well. So it's very important to realize when to stop doing the hydrodissection, and every particular step of the surgery has to be thought of and taken care of nicely. Now this is me doing 2 surgeries. This is my usual procedure for taking out some milky fluid and decongesting the capsule, and as you can see it goes on well. But this is an intumescent cataract in a pediatric patient, and see what happens. So I go in, and this is what happens. So every day is not the same. So one has to realize that things can go wrong even with your routine technique. So what to do in such a situation? Just stay calm, assess the situation, take a deep breath, put in some visco. I think this putting in some visco into the anterior chamber is something that actually gives you a breathing space, give you some time. Say what happened to this patient. So after I took this deep breath and went ahead, this is what happened. So you can manage it. You need to have microrhexis forceps and some maybe scissors, micro scissors. Saurabh was just showing. So this is how this patient went, and I put in a multi-piece lens. This part was easy. The next part, which was coming up, was more difficult. What was that? Well, this was what was inside the retinal detachment with the PVR in a pediatric patient. That was the difficult part. So just take a deep breath. You can do most of the things. Now let's move on. So this. So like I was mentioning, it's important to maybe even practice in normal cases. Putting in some visco with your left hand or your non-dominant hand. That is sometimes very essential, so that you have this thing registered in your mind that this is something that I'm going to do, and that can save your day. Now this is as you can see, this is a PPC, and visually obstructing for the patient, and the surgeon did a right decision in going ahead with the cataract surgery. But unfortunately there was a PCR. So where did I come into the picture? I came in here. So when I was sort of asked to take over, actually you can see the PCR here. You can see the surgeon has nicely brought up most of the lens matter into the anterior chamber, and you can see the PPC thing here, the posterior polar cataract here. So what did I do? Same thing. I just went ahead and I put in some visco first. So just to assess. So this is what I did, and you can see you can go in straight with the phaco and go straight for the nuclear or the lens material and do your phaco there, provided there is no vitreous prolapse. There was no vitreous prolapse here, and so I went ahead and this was just done in a jiffy. This is into 2 times, so it came out just like that. And you need to stop there, put in some visco, and then this is again slightly speeded up. So I went in with a bimanual and I just removed the cortical matter, and this wasn't really something that was very difficult, and all of us can do it. So this was the end of the cleaning part and or the IA part, and this is when I put in the multi-piece lens. Patient was anyway slated for a multi-piece lens, and at the end of the surgery, it is very important to check whether you've left around any vitreous. Shibashi showed very nicely triamcinolone acetonide, but you can, if it's not available, or sometimes I don't use it for the fear of glaucoma and all that stuff, so you can do it just like that too. Now, if support is inadequate, then you can leave the patient aphakic for a secondary IOL later or a VR surgery later. Now, key don'ts are avoid chasing the drop nucleus. Once the nucleus starts dropping, don't put your phaco tip, close to the area of the PCR or something, and go inside and try, taking out the nucleus. That's going to be damaging. And don't attempt to retrieve pieces via pars plana without appropriate equipment. Protitha does a lot of removal, when he has, these issues. I've seen beautiful cases, but he has all those equipment. So, this is not tough. You can do it, but you need to have the right equipment for you. But before referring, if this is a patient which you could not manage somehow and you need to refer, there are certain golden things that one need to do. Inflammation has to be controlled. intensive topical steroids and cycloplegics are necessary. This is an august house. I don't need to tell this, but for maybe some of the juniors, consider using systemic steroids if the patient is not diabetic to reduce the phagotoxic uveitis that can set in. IOP control is very important, and antibiotic coverage is mandatory. Now, you can communicate with your friend and, just maybe tell this is what happened, or maybe the anterior capsule is okay or not okay, or, so that the VR surgeon is, sort of focused on how to convince the patient that this was something that was bound to happen. So when a patient comes in, what I tell for anybody, in-house, out-house, I tell one thing, আপনার লেন্স বসানোর জায়গাটা ঠিক ছিল না, তার জন্য ডাক্তারবাবু লেন্সটা বসাতে পারেননি. That is the only thing that has to be told. I have done a mistake is something I think you should not be telling to the patient in today's situation and context. So I think লেন্সের বসানোর জায়গাটা ঠিক ছিল না, that is not a wrong statement, it is not a মিথ্যে কথা নয়. So সেই জন্য লেন্সটা বসাতে পারলাম না. Rest of it can be taken up later by the VR guide. Now, it's important to prevent a drop nucleus. So, there are various situations where we can realize that, we probably will not be able to, do justice to this patient. So, it's important to do a proper preoperative slit limb examination, maybe a IO, dilated, examination of the anterior segment to see whether there is any zonular laxity, dialysis, or, something else that can, hamper your, cataract surgery. And one has to, these CMEs are so important, and outreach is so important, because we have to be abreast with the current techniques. The newer techniques help us to refine ourselves, and it enhances our safety, and we can give something back to the society. And lastly, preparedness of having a clear action plan and necessary equipment for any complications. So to conclude, most importantly, stay calm, take 2-3 deep breaths, put in some visco, and just take it. I mean, like it's a tonic. Visco could be a tonic into the anterior chamber, could be a tonic for all of us. Proper anterior vitrectomy, stabilization of the anterior segment, and aggressive anti-inflammatory measures and prompt referral are some of the cornerstones of managing drop nucleus in peripheral setups. But most of it, we will be able to do it ourselves. We, in the sense cataract surgeons, will be able to do it ourselves. Thank you so much for your kind attention.
Thank you, Devdulal. We all now know, or we already probably know, that what to do when there is a PC tear and you're going to drop the nucleus. I think most of us don't try to go and fishing. But the most important thing what he said, and that's why he is so popular among all the ophthalmologists around, the counseling. The thing he said just in one word, that there was something in that support which was not right, that's why it could not be done. And that is so reassuring to the patient, so that for the surgeons who did the surgery, and they get very much all the agitation, all the problem, that actually they get reassured, and the surgeons, they feel go back to the surgeon again. Thank you, Devdulal. And because of the time constraint, just only a few questions, and from the chairperson, Samolda.
Before sending to you, should I put the air in the anterior chamber or the BSS?
Actually, the chamber, the only thing is that the chamber should be formed. There should be any leaking. For the time the patient, many times it might not be possible for the patient to come on the same day. So it's ideal to close the anterior chamber, maybe with hydro, or maybe with a suture, or
Stitch.
Stitch.
Better.
Air is not mandatory, sir. I have no issues, but depends on who your VR surgeon is. For me, put in the IOL. It saves my time.
Thank you so much, Devdulal, for now. I think we can take out 5 minutes for our inauguration session. I request our president, sir, our secretary, our organizing team, and the seniors to please come forward for the inauguration. Before that, we would like to run a small video. Please run the video.
colleagues and respected guests, Namaskar to you all in this nice morning at this Amrakunja for attending the outreach socio-academic program of West Bengal Ophthalmological Society. I must praise the idea of this sort of program as it is very useful to create better bonding among rural and urban members of the society. Here in Hooghly, it was started with much effort by Dr. Sudipta Mitra with the help of all members in 2018. Hope you will enjoy to your satisfaction as there is enough scope in this program. Wish the program be of grand success. May God bless you all. Thank you.
Everyone, good morning. Warm greetings to all my seniors and dear colleagues. It's always such a pleasure to join this very special meeting. The Hooghly District Outreach CME by OSWB. To me, it is not just a congregation of us ophthalmologists. It is a convergence of minds, a confluence of ideas which, like any other good conference, stimulates us, challenges us to seek answers, more importantly, to ask the questions. So, whether you are on your early career path or on a seasoned pro circuit, it's your involvement that really matters. Unfortunately, due to a freak accident which led to a foot fracture, I am unable to join this meeting in person today. But at the request of our OSWB scientific chair and one of the most identifiable faces in Hooghly, Dr. Sudipta Mitra, here I am, very much a part of you all. I will regret missing the opportunity to engage one-on-one with the distinguished gathering that you have today. But my thoughts will be with you as you go through the day, redrawing the boundaries of your knowledge and skills. Definitely I will miss the spirit of collegiality and the warmth of hospitality that has always been the hallmark of any event in Hooghly, more so in this CME. It has been, like 8 years now, and I still remember the first time I was here with you all in the year 2018 maybe. It all seems like yesterday. In the closing, I wish you all the very best for a successful and memorable meeting which will cement the bonds of our old friendships and fellowship, and also it will enlighten our path to the new ideas and collaborations. Thank you, dear organizers, for your kindness, for your tremendous efforts, for your thoughtful understanding and continued support. And to the audience, may I dare say, Today, it's very important that you listen to all. But it is all the more important that you eat well. And lastly, it is most important that you all stay well today and always. Thank you for the time. Take care and cheers. Thank you.
I request our President, Secretary and the organizing team, please, Dr. Arup Ghosh, Dr. Shamul Pandey, Pinakida, Shumon, please join hands. And all the seniors, please come up for Shekhar Sharkar, sir. Pradeep da, please. I don't think each one of you is very close to my heart. So please come proactively, please, madam. Sir, Mrinanda, Anjanadi, Mondiradi, please come, yes. If I am missing someone, please come up. Yes. Can I have? So long live OSWB and long live our Hooghly CME. Can I have a round of applause, all of us, for ourselves? Because it is us who make this CME a success. Thank you, sir. নিশ্চয়ই
এটা নন একাডেমিক কথা, কিন্তু খুব বেশি রিমার্কেবল একটা কথা বলছি। আমরা যারা অপথলমোলজিক্যাল সোসাইটির অফিসিয়াল মিটিংগুলোতে থেকেছি মেম্বার হিসেবে, এক্সিকিউটিভ মেম্বার হিসেবে বা কোনো পোস্ট হোল্ডার হয়ে, আমরা দেখি আমাদের মান্থলি মিটিং, যেটাকে এক্সিকিউটিভ কমিটি মিটিং বলে, তাতে প্রথম মিটিংয়ের শুরুতে যেমনি করে প্রেসিডেন্টের গলায় মালা দেওয়া হয়, তেমনি মিটিংয়ে খুব রেয়ারলি দুজনেই থাকেন, সেক্রেটারি বা প্রেসিডেন্ট। কখনো হয়তো প্রেসিডেন্ট ইলেক্ট থাকলেন, প্রেসিডেন্ট পারলেন না, সেক্রেটারি মোস্টলি থাকেন। কখনো হয়তো সেক্রেটারি কোনো কারণে বাইরে যেতে হলো, এরকম হয়েই থাকে যে এ আছে তো ও নেই, পরের জনের নেক্সট পারসন অ্যাটেন্ড করে নিলেন। কিন্তু আজকের দিনের এরকম ডিস্ট্রিক্ট মিটে both president and secretary and treasurer কোথায় রিপক্ষে লুকিয়ে জার্নাল এবং সেভারাল পাস্ট প্রেসিডেন্টস, আমরা সবাই এমনি এত বড় একটা অ্যাসেম্বল হওয়া, এটা খুব রেয়ার, সবাই আছে। That is excellent. I should mention.
Thank you, sir. Yes, it is true that without everybody's effort, this can never be a success. So the young guns like Shibashish and all our, see, like Diptesh has come all the way from Baharampur. So without all of us, I don't think so this will never be a success. I don't want to waste much time. We have other sessions too. So thank you all. And with that, I would hand over to the moderator of the next session, who is none other than Dr. Aniruddha Maiti and Dr. Siddhartha Ghosh. The session is on ethical practice. First is Dr. Debashish Dotto.
Good morning to one and all, my respected seniors and my dear colleagues and juniors. So our next session is on ethical practice. It has become very important nowadays to safeguard ourselves as doctors from a litigious society, that does not treat us like human beings. So it is always better to be safe and to do what's best for the patients as well as for ourselves. So we'll move on to the first talk. Our first speaker is none other than Dr. Debashish Dotto. A lot of patients come to us, cataract patients. We have all faced these patients complaining of নেগেটিভ ডিসফোটোপসিয়া, যে ডাক্তারবাবু এরকম একটা সাইডে একটা শ্যাডো মতন দেখছি। তো ইন দ্যাট কেস হাউ ডু উই অ্যাপ্রোচ দোজ পেশেন্টস? Before we begin the talk, I would like to call the respected chairpersons, Dr. Shekhar Sharkar and Dr. Milan Kanti Ghosh on the dais. Please, sir. Co-chairperson, Dr. Saurabh Sanal, sir. Sir, please come on the dais. I'd like to call upon the panelists, Dr. Ananto Banerjee, sir, please be on the front row. And Dr. Arindam Sadhu, sir.
Good afternoon, everybody. I thank OSWB and the Hooghly people for having me here. I'm a part of the Hooghly district itself. So without further ado, let's talk about patient counseling in negative dysphotopsia. Negative dysphotopsia, as we all know, is a dark shadow in the temporal field of uncomplicated cataract surgeries. And for uncomplicated cataract surgery, we need to be good surgeons. And that's why we all are here. We all are good surgeons and we all have it. So it may be temporary, it may be persistent, and it can be late onset also. Etiology, we don't know it, so let's not go into it. So why are we talking about negative dysphotopsia now? So the incidence is very high, from 0 to 77%. So why there is so much of variation? So if we solicit the leading question, do you see a black shadow in the immediate postoperative period? Many of the patients will say yes. But if you don't ask, they will just ignore. You can trivialize it. But the silver lining in the cloud is, from that very high percent, an average of 26%, it comes down to 0.05% over a year. So, but given the amount of volume of cataract surgeries that we do, even this 0.5% is not insignificant. So characteristics, we know it can be prevented by hand, and the spectacle frame takes care of it, more on adduction, less on abduction. So what to do? Right at the beginning, patient counseling and reassurance that it will go away within 6 to 12 months. Put on your specs. And why do you all this? All this, we allow it for neuroadaptation to take its place. But if it does not, you can take help of some mydriatics. It might help. If you want to do something interventional, but conservative, a ear capsulotomy can be done of the anterior capsular edges to change the orientation of the optic. But if it does not help, then we have to go in for something surgical. So surgical may be IOL best, or some IOL, we can go in for IOL exchange or some additional things. Let us see one by one. So right at the beginning, we can place a multipiece IOL in the sulcus itself. A multipiece IOL can safely be placed in the sulcus. Nobody is going to raise an eyebrow. So it can be placed in the sulcus, and usually it does not cause, rhexis capture can be done. Usually it does not cause negative dysphotopsia. Now, if the lens is there in the bag itself, slow. So this multipiece IOL is sitting square in the bag and producing negative dysphotopsia. You take it out and place it in the sulcus. This takes care of the negative dysphotopsia in most of the cases. Now, if you do not want to take it out of the bag, you can nudge the optic out and do a reverse optic capture. So take the optic out of the bag and leave the haptics in the bag. So you have this posterior capsular fold signifying that the haptics are in the bag, but the optic is over the rhexis margin. In case of a toric IOL or a single piece lens, it is a little bit more challenging, but reverse optic capture can be done. It is more time consuming, but one advantage is that in case of toric lenses, if you do a reverse optic capture, there may be a little bit of myopic shift, but the lens is not going to budge. It is going to stay put right in there. It is not going to rotate by even 1 degree. So it is a little bit time consuming, and the rhexis, the axis alignment has to be done. So these are you keep the same IOL in place. But if you have to go in for an IOL exchange, different types of IOL are available. The oval optic IOL is available, where the optic diameter is about 6.5 millimeters. So this takes care of negative dysphotopsia. Now, Dr. Samuel Masket has designed a special kind of IOL, which is partly inside the bag and partly in front of the rhexis margin. The rhexis has to be of a particular size, rexis fits in there, in this gap in the lateral aspect of the optic. So part of the optic is in front of the rexis, part is behind the rexis. So this takes care of negative dysphotopsia if the part of the IOL is in front of the rexis. Now, this negative dysphotopsia is an edge phenomenon. So it happens at the optic edge. Now, in case of plate haptic lenses, you don't have this sharp edge. This edge is staggered to the periphery. So usually plate haptic lenses placed horizontally does not produce negative dysphotopsia. But mind you, usually these lenses are all hydrophilic ones. Now, advanced surgical techniques. So this is a negative dysphotopsia ring, like the one which you have seen in the morning, but there's a gap in the center. There's nothing inside. So this portion of the lens sits on top of the optic edge. So let's see how it goes. It's a hydrophilic lens put on top of a hydrophobic lens. Sorry. So here it's a bulky lens having very thick haptics. So there are 4 haptics. You've seen it in the morning. It is very difficult to place those haptics behind the iris. You gradually place it behind the iris in front of the rexis margin in the posterior chamber. And let us see what the patient testimonial says. চলবে
এটা ছাওয়াটা নেই এখন মাঝখান দিয়ে একটু হেজি মনে হয় চশমা পরে ঠিক
আগে কি রকম ছিল
আগে মনে হতো কি চোখটা ছোট এরকম
কোন জায়গাটা ছাওয়াটা ছিল
এই কোণা দিকটা
এই কোণার দিকে ছাওয়া ছিল এখন যে অপারেশন পরে সেটা নেই
Now, this is something which I've done lately. So, let's see what the patient has got to say.
কিন্তু আমার বাঁ সাইডটা যেন মনে হচ্ছে একটা কেউ কাট করছে
কোনখানটা দেখান দেখি
এই এরকম জায়গা থেকে জানো
So I laid my hands on a zero diopter phakic IOL. So it has got no power. I injected just like you usually do in case of correcting myopia and the like. So this IOL is injected below the iris, and the results in the immediate post-operative period. Let's see. আপনার একটু আগে অপারেশন হলো তো?
হ্যাঁ হলো আগে আগে যেমন একটা গার্ড লাগছিল এখন অনেকটা ক্লিয়ার হয়েছে
আর সাইডের ছাওয়াটা নিয়ে আমরা চিন্তিত ছিলাম সাইডের ছাওয়াটার কি খবর
ছাওয়াটা এখন মোটামুটি ঠিক আছে
So this is the vault in between. This is the pseudophacus, and this is the PMMA lens sitting in the back, and this is the hydrophilic lens in the sulcus. So this is the sulcoflex lens made of It is placed in the sulcus again over on top of the IOL sitting. It is usually of a different material we would choose. If it is of a hydrophobic material in the back, we will choose a hydrophilic material to sit in the sulcus. Now this man has got trifocal IOLs in both his eyes.
একই রকম ছিল কিরকম ছিল দুটোই এরকম করে ধরলে বন্ধ হতো আর নালে থাকতো এখন ডানটা চলে গেছে একটু আছে চশমা চশমা পড়লে আর কিছু নেই যার জন্যই তো সব
কোনো পাওয়ার নেই তাই তো
না নেই
কোনো পাওয়ার ফলস থ্যাংক ইউ
তিনটা কম চশমাটা খুললে তো সব বেশি আর এটা দিলে কম অনেক কম
অনেক কম ঠিক আছে সরিয়ে নিন এবার ডান চোখটা ঠাকুরকে চেটো দিয়ে জাস্ট ক্লোজ করুন এবার
একদম কমে গেছে
কমে গেছে না চলে গেছে
আর একদম
না চলে গেছে ছাওয়াটা চলে গেছে তাই
চলে গেছে
টোটালি
চলে গেছে টোটালি চলে
চোখের কোন জায়গায় চোখের জায়গায় এই জায়গাটা মনে হচ্ছে কি ঢাকা রয়েছে আচ্ছা ডান চোখটা বন্ধ করুন তো ডান হাতে চেটো দিয়ে এখন ওই ছাওয়াটার কি হলো আবার ছাড়ুন
Somebody said there's nothing much to it. We just leave it to its own. It will resolve. Trivialize it, make the patient carry on with normal activities. But senior person also said, why do so much of hanky-panky with something which is irrelevant, which is of not much of importance? The patient can see everything. In answer to that, I have collected this video. Let me see what this man has got to say. And this is a 2-year-old case.
কিন্তু কিছু তো কোনোদিন বের করতে পারেন না কতদিন হলো অপারেশন হয়েছে বছর দুয়েক ধরে প্রত্যেক দিন এটা আপনি অনুভব করেছেন?
হ্যাঁ, এটা মোটামুটি অনুভব করছি, কিন্তু আমার ভিশনে কোনো প্রবলেম নেই।
এইবার
চশমাটা মনে ফিলিংসটা কম হয়।
তা আপনাকে যদি কোনো অপারেশন, আরেকবার অপারেশন, একটা ছোট অপারেশন করা হয়, তাহলে তাহলে কি আপনি করবেন? সেটা করলে এই ছাওয়াটা চলে যাবে। আপনি করতে রাজি আছেন? আপনি কি খরচা করে অপারেশন করতেও রাজি আছেন?
আমার মেডিক্লেম আছে, যদি মেডিক্লেম না চলে খরচা করতে হবে।
আর কি 2 বছরের প্রত্যেকটা দিন এটা আপনি অনুভব করেছেন? কিন্তু এটা আপনাকে সত্যিকারের প্রবলেম দিচ্ছে?
মানে আমার ফিলিংস হচ্ছে, মনে হচ্ছে
আপনার তো 2 বছর হয়ে গেল। এই 2 বছরে কি একই রকম আছে, বাড়েনি কমেনি?
না, কমেছে অনেক,
কিন্তু আছে
একটু মনে হয় আসেনি, একটু হয়ে গেছে।
So what is persistent even after 2 years? I think you can't just let it go like that. So these are a few post-operative pictures. So present understanding is, if you want primary prevention, larger optic diameter is good. Plate haptic IOLs can be done, or some specialized IOLs like masket lens. And if it is there in the bag, if you can use piggyback lenses or a reverse optic capture can be done. Thank you. Thank you, Hugli.
Thank you, sir. Sir, before I give the mic to the panelists, can you mention the costs of this ND ring and zero diopter phakic IOLs?
I do not use in my practice. This is off the level use. This is one I have done. If there's an ND ring, somebody has got a patent on that. That is Dr. Prakhyat Roop from EMS. He has got it. So I could not lay my hands on that IOCare material at that point of time. Somebody gave me a zero diopter sample lens, sterile obviously. So I put in that and I noted the results in the OR itself. It was miraculous. So maybe it can be done. Maybe I can do a case series someday.
No, okay. Actually, I have a presentation on unhappy 6/6. Unhappy 6/6. So one of the reason is this. So it's basically till now I think these are all trial and errors we are doing, but as all the international faculties in all the conferences, it has been discussed that it goes away. If you just like Dr. Mohan Rajan was there, he said ki you can ask the patient, or you create another problem for the patient and you treat that and he will not come back with the negative dysphotopsia.
So that, for this thing, that patient testimonial for the last estimation. The last.
We don't disagree with you, whatever you have
What
presented.
will you do to that patient? It is not for all and sundry, but somebody who is really having a problem, we have to give him some cure.
In my presentation, as I said, that there will be a lot of changes in the capsular fibrosis, so age, defect, everything will be taken care of with time.
You don't interfere before 1 year of it. After 1 year, if it is persistent, then only you think of something, not in the immediate post-operative period.
Patient is so much bothered about this, then you can think of doing all this thing. Otherwise, if you counsel the patient, and time will definitely solve this problem.
Neuroadaptation.
And this.
We move on to the next presentation. Pinaki sir, our lovely, very lovely Pinaki Nag sir, for the person behind the Hooghly CME. His topic is counseling a patient and family after a complicated phaco surgery. This is very important topic. We should all be listening attentively. Over to you, sir.
Thank you, Siddhartha. That's my talk. That's the counseling of a patient and family after a complicated phaco surgery. I am sure all of us has actually undergone these kind of problem and had to face and had to deal with it. And I don't have any financial interest, but why me? Why I am doing this talk? Because our chairperson scientific committee has chosen me, handpicked me to give the talk, because he believes I am the person, I am the surgeon who does get most of the complications. So here I am and doing the talk. And how I deny her that I can't, because she is my, after all, parar mein. Ki kore bolbo na? And just the course or the facts. Only the surgeons who do not have any complications are those who don't do any surgery. That's the fact. A good surgeon is not one who never faces complication, but one who meets them with honesty, skill, and unwavering care for the patient. Complications do not define the surgeon, but how they respond to us. That's what I want to tell my para maker. Is don't handpick on me next time. Surgery is the art of healing, and part of that the art is guiding the patient safely through the unexpected. Before I actually go into the talk, I should share these two incidents which happened in my early PGT time when nearly 30 years ago. I used to, when I was doing PGT in RKM, and I used to go out to assist the seniors. So in one of the day, I went with a very senior consultant, and the nursing home where we went to, there was another surgeon who was the stalwart that time in ophthalmology in Kolkata, was doing the surgery that time. It was extracapsular and IOL. And when we entered the hospital, there was something thum above. At you could feel something is not right. When we entered the surgeon's room, something is not right. And we were told that there will be delay for you to get the theater, another at least couple of hours. Then we realized what happened. The patient died on the table. Came for the cataract surgery, the patient died on the table. Cardiac arrest, whatever, and they had to do whatever. But the interesting bit, there were a few people I could see coming, and the consultant who was sitting with us he was very, very quiet, calm. He was going 2-3 times. He went out and just spoke to 2-3 persons and came back very composed, relaxed, as if nothing has happened. I peeped out and see there was no commotion, although it is 30 years ago, the situation was different here, but the most interesting thing is that he even went back to do his last case even after all these things. So he managed to finish another case before we could get in, but there was no commotion, there is no problem, all quiet, and the patients were, patient party, whatever counseling he did, the patient party didn't do any problem. So we finished this case ourselves as well afterwards. And the next incident is involved in Mama. Amar Nijer Mama. Amar Mama, he was an engineer, and he was the DRDO of, he was the director of DRDO of Hyderabad. But he is that type of guy. If you tell him something, he will ask you 5 questions. Why, when, where, why it would have done differently. I was scared in my childhood that he would, if he picks on me about my study, I'll be in a mess. So he will ask 10 questions. This Mama, who is no more now, and he was very high myopic, and he chose to get operated for his cataract surgery by another very, very stalwart at that time, very renowned consultant, and he had a PCTR. High myopic PCTR, but the consultant managed to finish the case with a sulcus fixation lens, but he ended up with 636 vision with secondary glaucoma. That's not interesting. That can happen to anyone. But the interesting bit, which I came to know after 4 to 6 weeks time, that surgeon and his whole team was invited for a Sunday lunch in my mama's house. That was amazing. That mama's house, that consultant with his whole team went for a lunch, a Sunday lunch. That is interesting, and that's what the counseling is. That's what we should learn from those, seniors of us. So 2 incidents I thought I should share. Now when a complication happens, the first reaction of ours is, oh my God, what to do? But you calm down. Buddhang saranang gacchami. Just think of, just relax. You just utter Buddhang saranang gacchami and it will settle down. So what are the different types of complications you can have when you go for cataract surgery? There's extraocular, there's the cardiovascular, anaphylaxis, asthma attack, panic attack. Local anesthesia induced, that is irretrievable by hemorrhage, globe perforation, although it's very rare because most of us are doing it as a topical, and the phaco-related. And the different types of ocular complications are predisposing and intraoperative. The predisposing, as we all know, is the traumatic, subluxation, PPC, and short eye. But the good point is, patients are already counseled that there will be a high risk problem, there will be all different complications we might encounter, but we will try to solve it. So the counseling bit is not that difficult. But the problem happens where there was nothing, like many of the presentation we actually seen this morning, there's out of the blue something complication happens. So the PCR, heart globe, iris stoma, bleeding, hyphema, no IOL, and desperate membrane detachment. So these are the list. The PCTR, conversion from SICS to ECC, nucleus drop, not the chosen IOL and no IOL, the question out of the ask to Sudipta, no, the other person, that why, what did you counsel, how did you counsel the patient where the right lens was not chosen, you had to choose a different lens. So it's a difficult job, but you can actually convince that you are trying the best for the patient. Disment detachment, it can happen, and you know in the long run there might be some problem, but you can deal with it. Wound burn, damaged IOL or exchange IOL, iris trauma, and hyphema. And what are the implications of that? The immediate shock to the patient, because patients are now under topical, they realize what's going on, why it's taking so long, and the discussion or the conversation between the staffs and the surgeon, patient can assess something is not right. So patients also understand there is something is not properly, whatever should have had, not now, it's taking a longer time, and there will be visual compromise, the pain and long period of convalescence, further surgery, sometimes to be referred to another center, and for that there are logistics and cost factors involved, to face agitation by the patients and relatives, especially nowadays, and bad day and disturbed sleep for the surgeon. And the counseling. The counseling a patient after complication from phacoemulsification cataract surgery requires a sensitive, honest, clear communication, reassuring approach, as already explained by Sudipta earlier. Our goal is to explain what happened, what the implications are, what are the plan of further management, and to maintain the patient's trust, which is most important. Like I give you example of my mama. যে মামা সেই কনসালটেন্টকে এক মাসের মধ্যে ইনভাইট করে খাইয়েছিল. Here is the structured approach for counseling. The first thing, when you counsel, create a supportive environment. So the room you take the patients or their family members in should be very private and quiet setting. Sit at the eye level, speak calmly, and allow the patient or the caregiver or the family members to express concern and emotion. It's very likely, very common that they will also get agitated because they could actually sense something went wrong. So they will be obviously agitated, but always better to have a nursing staff when you do the counseling. Acknowledge the situation. There is no point hiding the thing, because then or the later they will find out there was something wrong during the surgery. So always better to be honest and empathetic. Start with the reassurance that you are here to help and explain that what happened. For example, I want to talk with you about your surgery. While cataract surgery is generally very safe, in your case, there was an unexpected complication during the procedure. Explain the complications clearly. Avoid any medical jargon. You should tell in the language where the patient understands. Explains what should have been the patient, which patient can understand. For example, posterior capsular rupture, as Devdulal very nicely mentioned to the patient, that during surgery, the thin back layer of the lens capsule tore. This can sometimes happen even in experienced hand. Exactly the way Devdulal counseled the patients who were being referred to him. Drop nucleus and nucleus fragment, part of the lens slipped to the back of the eye, will do another surgery procedure to remove and protect your vision. Corneal edema, the front part of your eyes have some swelling. This can blur your vision temporarily, but we are treating it and expect it to improve. Explain the next step or the management, what you are planning to do. For example, we are starting on specific eye drops to help the eye heal, reduce the inflammation, and you need to come in more often so that we can closely monitor your eyes, because you are showing concern that you are also think of the patient that they get the best outcome. So that patient get reassured with your commitment. If further surgery is needed, you may need another short procedure. We'll do everything to make sure your vision is restored and as much as possible. Address the question and emotions. Encourage the patient to ask questions and express how they feel. Answer calmly and acknowledge fear or frustration. These are all important things. And just set a realistic expectation. Just don't say you'll get the best vision, you'll get what we promise, that 6-6 vision you'll get, but give a realistic. So if you can think that they can have 618, 612 or 636 vision, you should just accordingly just tell them slowly. Because of this complication, your healing might take little longer and your vision may take more time to improve. In many cases, patients still achieve good visual outcome, especially with appropriate follow-up and care. So that the patient just come back to you for the regular checkup. They may get so much frustrated, they might miss some appointment, they might go somewhere else, but you reassure that if you keep under observation, keep doing whatever we just advised you to do, you'll get a very good outcome. Rebuild the confidence and provide support. Emphasize ongoing care and your commitment. Reassure the complications, though unfortunate, are manageable. Cost may be waived or discounted. That's a big thing. That varies, I think, from different institute, from different individual. How you waive, how much you waive, or do you take hold of it? That varies. So I'm not going to talk about this. It's different people's different opinion. For example, although this was not the outcome we had hoped for, but this sometimes we can manage. We're going to be with you in every step of the way. That's a very reassuring statement you can give it to them. Whatever you discuss, you always provide a written instruction and follow-up plan. You have told the patient, but you should clearly write whatever you advise, and so that in future, if anything comes back to you, you have a clear documentation. So give a summary of what happened and treatment plan. Set clear expectation for follow-up visits, signs to watch for, and when to call. Document the discussion, that what you have explained, that the patients understood what you have explained, the patient for follow-up and referral, and name of the people present, in case there is litigation involved in future. Lastly, summary, give hope. That is the most important. Once Devasisda told me, never say, when the patient have say only PL vision, never say you are blind, you can't do anything. Just give some hope that in future, you never know, you can see a little bit more. That gives something to the patient. Otherwise, they get so much frustrated, so much depressed that I have lost everything. But that much of a little hope, okay, that can help. So I also feel that should be the case. You shouldn't bluntly say, no, you are blind, you can't do anything for you. Better say, yes, possible. We never know, not everything in our hand. You might see a little bit more in future. So complication can happen despite all precautions, but we have identified it clearly, are treating it carefully. Most patients still do well and recover with proper treatment. That's the last statement you have to tell the patient, and that's the take-home message. And I can tell you, thank you for listening. I can tell you, the life was much cooler over there when I was working in NHS. It was really cooler because that time we didn't have to face so much problem, so much, if anything goes wrong. So it is all government sector, and people are not like that here. And here, by the way, it is me just scraping the windscreen ice, and my son is dancing in the snow before I actually went for the hospital. Thank you very much.
Thank you, Pinakita. Excellent presentation as usual. I would like to share one incident, a medical legal case. This happened, there was a dropped nuclear matter, but unfortunately the operating surgeon never said the truth that there is a drop, and the medical legal case was for that, why the operating surgeon actually didn't explain what has happened. So as you correctly mentioned, the truth should be revealed. We should not hide anything. because that patient, then there was a drop, was taken care. Patient had a good vision, but the allegation from the patient party, especially his son, was that why the operating surgeon didn't say the truth.
That's the problem. Most of the communication gap is the main thing on every agitation on every problem in life as well. The communication gap. Better to be truthful and say we're trying our best.
I think
Somehow
more.
or other, they will definitely find out what went wrong.
I think the most of the medical legal cases happen because there is lack of counseling. It is not explained properly what has gone wrong, and that is the grievance that the patient party has.
Thank you.
And we should remember that complication is not negligence. So nothing to hide. We should explain to the patient.
Yes, of course.
In the interest of time, can we move on to our next speaker, Dr. Shankar Subro Chaudhary? ওই স্ক্রিনটা ওই কম্পিউটারটা The next topic is informed consent for ROP babies.
Good morning, everybody. I'll be speaking on the informed consent in retinopathy of prematurity. By definition, informed consent is a process in which a healthcare professional educates a patient about the risks, the benefits, and the alternatives of a given procedure or intervention. Now, for the clause of an informed consent, there are many sub-clauses that are written underneath it. First, describing the proposed intervention, then emphasizing the patient's role in decision making, then discussing alternatives to the proposed intervention, explaining about the risk and benefits of the proposed intervention, eliciting the patient's preference, and lastly to be confirmed by the signature. But it is most important to note that the consent forms express no guarantees that the proposed method can resolve the problem being addressed. Now, usually children cannot give their information, so their parents or the legal guardians give their permissions, and this is known as informed permission. Now, the next few slides are going to be extremely boring. Now, there are three components in cases of an ROP informed consent. First, about the timing, then the communication strategies, and lastly, the documentation part. Now, the timing has two things. One, prior to the ROP screening, and second, before going into intervention. And for the communication strategies, use simple, non-technical language in a language the patient can understand. Use visual aids or diagram of the retina and the disease process to make the parents understand about disease. Inclusion of both the parents and legal guardians whenever possible. The ROP patient's mother are actually emotionally they are emotionally unstable because they don't know what is actually going on with the patients. So addressing the emotional distress emphatically and allowing time for the parents for questions and their reflection. And lastly, to document. For the documentation, we have to specifically nature the procedure. We are either going for lasers or any interventions. The detailed risks involved with the procedures. For injections, we can have endophthalmitis, we can have cataract. Include parental signature with the date and to be witnessed by a clinician or the nurse. Now, why there is a need for the informed consent? For the ethical obligations respecting the parental autonomy, for the legal requirements of the COPRA, we all know there is a medical judicial requirement for a consent for every patient and for a shared decision making. For the legal perspective, for the consent form must be comply with the applicable medical and legal standards. For any invasive procedures like injections or lasers, there should be a written consent. For any ROP screening, it is usually a verbal consent, an implied consent, and we have to document and record everything. For emergency, like for stage 5 A, B, C, D, if there is an emergency surgery is required, we can go ahead with an emergency consent. So before the screening of the ROP consent, use the most recent and accepted guidelines. Before this, the consent before the screening is actually an implied one, and do communicate the patient party about the dilatation procedures, the apneic spells that may happen during the procedure, and the conjunctival hemorrhage. The most recently accepted guidelines in India is the RBSK guidelines published in 2017. We can see there is a ROP recording from the screening and there is a follow-up form. But for the ROP evaluation form, the 4 things are very important. First, actually highlight the risk factors, the maternal and the neonatal risk factors. We often forget to mention about the anterior segment findings, but we have to actually document the anterior segment findings also. And then as we usually dilate and see the patients, we have to document with the clock hours and the zones. And lastly, the most important is the follow-up. Please mention the date, the time and the doctor for the follow-up is needed. The date and time is very important, not just to say that come after 7 days. For the ROP recording form must be kept in the NICU, and one should be kept in the hospital itself, and one should go with the patient party. So that for every ROP patient for recording there should be 3 forms. And for any interventions, there are mainly 3 interventions. First, there is a lasers. The lasers have a consent have mainly 2 parts. The first is a declaration by the doctors, where the doctors state that I have explained the nature and consequences of the procedure to be performed and discuss the risks that particularly concern the patient. And the first part is the declaration by the patient party. And the patient party declaration has 3 main key components. First, the patient says that I have clearly explained about the laser procedure, its side effects and the risks involved. The second is depending on the severity of the disease and the treatment response, additional lasers may be required later. And thirdly, the patient states that I understand that despite the best effort for the laser treatment, sometimes the disease may progress, leading to visually disabling sequelae and blindness. And then come for the injection parts. The injection parts, the patient states that the procedure is being done as this is necessary to save the vision of my child's eye, and which has been affected. This is also explained to the patient, and which she signs that the details about the risk of the infection in the eye and bleeding elsewhere in the body is also given. And for the high risk consent is mainly for the surgeries, and it is very important that despite all precautions during the process of the surgery, the patient states that I am consciously aware of the risks or the complications that may arise, which is already disclosed to the physicians. And lastly, the most important line, I will not hold neither the doctor, hospital, nor the staff for any consequences and side effects based on the surgery. And you can see there is an open funnel type RD. But the challenges we face in consent for ROP is the emotional stress, because the parents of the preterm infants are actually overwhelmed. There are so many treatments going on, and that impairs their ability to understand the medical information. We often communicate with the patients in the medical language, but it is better to speak in the native dialect or use the translators or culturally sensitive materials or persons. And lastly, we all know that awareness, though it is increasing, but the awareness for ROP is still very low. So education is essential. So in conclusion, I would like to state that informed consent is not just a signature, it's a communication process. Timely, emphatic and clear discussions are critical, and proper consent protects both the infant and the medical team. It is boring but essential. Thank you.
Thank you, Dr. Shanku, for an excellent presentation. I think we don't have much time. We need to move to the next talk. I think one thing what we can add on to your presentation, sometimes a pediatrician help is also it's required, because at that stage, I think along with the ophthalmologist, if the pediatrician also emphasize the need for the treatment, it helps.
This is absolutely, I mean, whatever you have told, absolutely correct. The most important is that is the delicate handling of the parents, psychology. The treatment, you can do it very well. The delicate, I'm using the term deliberately, the delicate handling of the emotion of the parents. That is the most important, because that
treatment you are doing within 48 hours or 72 hours when it is needed. So patient has to decide immediately. পেশেন্টকে বাচ্চাকে শুধু চোখে একটা ক্লিপ লাগিয়ে দেখতে গেলেই তখন মা ওখানে বসে বসে কাঁদতে শুরু করে দেয়। আর যখন তুমি বলবে চোখে ইনজেকশন দিচ্ছি, লেজার করছি, তো মা ওখানেই পারলে পরে ফেন্ট হয়ে যাবে। সো দ্যাট পার্ট ইজ ভেরি ইম্পর্টেন্ট অ্যান্ড this is an art of how you put in front of the patient. So that's how the consent part, everything goes off very well and very well put.
Thank you. So we move on to the next, ethical use of newer molecules in myopia. Dr. Shuman Mukherjee.
Good afternoon, everybody, and welcome you all in our Hugli program. We are running short of time, so I'll go very quickly. What is a new molecule? It can be totally a new molecule, or it can be a slight modification of the older molecule, or it can be a new drug delivery system, or a higher strength or lower strength of the known drug. So we all know this thing, but what is the main problem as a doctor, particularly in terms of medico-legal aspects? So we are in between the ethics and legality. So there are two things we have to take care of regarding the ethics of using a newer procedure, newer drug, newer molecule, and with a legal thing in our mind. Now what ethics says, whether it is tested properly. 90% times the tests are done in a Western world, and in our court always they ask in nowadays whether that same study was done in your setup, in your ethnicity, in your locality. So keep in mind, when you are using a novel molecule or newer molecule, find out the supporting at least one journal, and at least that must be an indexed one. Safety assessment must be done, like the toxicity profile, because কি ভালো হবে জানি না, কিন্তু খারাপ যেটা হবে that will take you to the consumer court, to medical council, and ultimately your life will be in trouble. And responsible innovations, these are a concept like whether it has been done with actual ethical things maintained in every steps, and permission from the regulatory bodies like FDA approval. In our country, the approvals are theirs or not. Now, informed consent, already told by so many previous speakers in ROP also. Informed consent, particularly if you are doing some new study. In that case, if a person is not giving a proper consent or in a written consent, better to take a video recording. Particularly when we are conducting a study, video recording nowadays are becoming almost mandatory. Instruction to use versus the whether আমি ইউজ করেছি এতগুলো is not the concept nowadays. যে আমি একটা সাইনাস পাই, সাইনাসে আমি অ্যান্টিটিবি ড্রাগ দিয়ে দিই, that will not safeguard you. Possible complications and significant known works that you must keep in your mind, and definitely always judge the potential risk with the potential benefits, and always keep in your mind every patient, just like right to treatment, they can right to refuse, particularly when you are conducting a study. আমি স্টাডিতে তোমাকে ইনক্লুড করেছি মানেই তোমাকে আমি জোর করতে পারবো না টু কমপ্লিট দ্য স্টাডি। ইউ ক্যান রিফিউজ অ্যাট এনি পয়েন্ট, অ্যান্ড ইভেন রিফিউজ করলেই হি ক্যান গেট দ্য বেনিফিটস, পার্টিকুলারলি ওর যদি কোনো কমপ্লিকেশনস হয়ে থাকে, উই আর বাউন্ড টু গিভ দ্য benefits that is already আমরা সাইন করিয়েছিলাম during the consent taking. You may not start the molecule, but better to know and inform the patient, or you may not know that you must acknowledge পেশেন্টকে জানানো যে ভাই এই জিনিসটা সম্বন্ধে আমরাও খুব ভালো জানি না, এটা নতুন একটা স্টাডিতে এসছে, আপনার যেহেতু অন্য কিছুতে কাজ হচ্ছে না, সো উই ক্যান ট্রাই দিস। অলওয়েজ টেক দ্য প্রপার কনসেন্ট অ্যান্ড ডকুমেন্টেশন। 90% কেসে যেগুলো মেডিকেল কাউন্সিলে আমাদের কাছে আসে, ডকুমেন্টেশন ইনঅ্যাডিকুয়েট থাকার জন্য দেয়ার ইজ আ প্রবলেম। ইফ ইউ আর নট ডকুমেন্টিং, দ্যাট মিনস ইউ আর নট ডুইং দ্য থিং। সো ডকুমেন্টেশন ইজ ভেরি মাচ রিকোয়ার্ড, অ্যান্ড পার্টিকুলারলি একটু আগে পিনাকিদাও বলছিল কমপ্লিকেশনস ডিউরিং সার্জারি। হ্যাঁ, ডেফিনেটলি সার্জনকে অল ইজ ওয়েল বলতেই হবে, করে তাকে সার্জারিটা করতে হবে, বাট অ্যাট দ্য এন্ড অফ দ্য হোল প্রসেস ইউ মাস্ট ডকুমেন্ট দ্য হোল প্রসিডিউরস, যে কোন স্টেপে গিয়ে তোমার কমপ্লিকেশনসটা হয়েছে অ্যান্ড হোয়াট সার্জিক্যাল ম্যানেজমেন্ট ইউ হ্যাভ টেকেন। তারপরে তুমি এক্সপ্লেন করেছো এবং পেশেন্টকে পাঠিয়েছো, এভরিথিং ইজ ওকে। কিন্তু অনেক সময় পেশেন্ট চলে যাচ্ছে কনজিউমার কোর্টে এবং সেখানে যখন ডকুমেন্টসে দেখা যাচ্ছে যে মানে একটা ছোট ছোট করে নোট দিয়েছে, ধরুন একটা অ্যানাস্থেশিয়ার এরকম কেস আমাদের কাছে আসছে যে একটা রিকভারি রুমে পেশেন্টটা খারাপ হয়ে গেছে, এক্সপায়ার করেছে, তারপরে যে নোটটা দিয়েছে একদম পাশে গিজি করে লেখা, চলে আসছে লয়ার এসে বলছে যে এটা নোটটা তো পরে দিয়েছে। সো বেটার টু চেঞ্জ দ্য পেপার, write it properly so that in long run you don't face that much of problem. একটা কেস স্টাডি আছে, লাইক a 8-year-old child, one eye 6/12, other eye 6/6, এর মায়োপিক পাওয়া গেছে দুটো চোখেই। নাও আমরা কি অ্যামব্লায়োপিক বলবো? অ্যাজ পার থিওরি 6/12 ইজ নট অ্যামব্লায়োপিক। এবার তাকে আমরা কি ট্রিটমেন্ট দেবো? স্পেকটেকলস দেবো, অ্যাট্রোপিন দেবো, প্যাচিং দেবো? তো এই জিনিসটা উই হ্যাভ টু ডিসকাস, অ্যান্ড যেহেতু আজ টাইম শর্ট, এটা আমরা পেডিয়াট্রিকের যেদিন প্রোগ্রাম হয়েছিল সেদিন আমরা লংলি ডিসকাস করেছিলাম, তো এই জিনিসগুলো আমাদের একটু মাথায় রাখতে হবে। দ্য সেম থিং অলসো ফর আ অ্যাডাল্ট, তার ক্ষেত্রে কি আমরা প্যাচিং দেবো না, তার ক্ষেত্রে কি আর কোনো ট্রিটমেন্ট করবো কি করবো না? কিন্তু অনলি থিং ওয়েন উই আর ডিলিং উইথ আ নিউয়ার প্রসিডিওর, আ নিউয়ার মলিকুল, পেশেন্টকে যে ইনফর্ম করা হয়েছে দ্যাট মাস্ট বি কেপ্ট ইন রেকর্ড। সার্জারির ক্ষেত্রে প্রবলেমটা কম হয় বিকজ উই হ্যাভ দ্য কনসেন্ট ফর্ম উইথ আস, বাট ওপিডি ক্ষেত্রে আমরা অনেক সময় কনসেন্ট নিই না। আমরা ধরে নিই যে পেশেন্ট এসছে, আমি একটা নিউয়ার অ্যাট্রোপিন হায়ার স্ট্রেংথ এসছে, আমি লিখে দিলাম। বাট যখনই আমি একটা হায়ার স্ট্রেংথ লিখছি, যেটা ইউজুয়ালি সবাই এখনও প্র্যাকটিস করে না, সো ইউ মাস্ট টেক আ কনসেন্ট ফ্রম দ্য পেশেন্ট। থ্যাংক ইউ ভেরি মাচ।
থ্যাংক ইউ। একটাই জাস্ট কোয়েশ্চেন, এ নিউ মলিকিউল যখন আন্ডার স্টাডিজ বললে, there are studies, no, rather we consider some molecule which has been FDA approved, ইন্ডিয়াতে কিন্তু স্টাডি হয়নি। তো what is the stand, medical legal stand?
এক্সপ্লেইন, ধর একটা নতুন মলিকিউল আছে, ইন্টারভিটাল ইনজেকশন, এটা এখন ইন্ডিয়ান সাবকন্টিনেন্টে স্টাডি হয়।
এক্স্যাক্টলি।
তো সেই ক্ষেত্রে পেশেন্টকে আই হ্যাভ টু প্রোভাইড অল দ্য ডিটেলস, এবং সেটা ডকুমেন্টেড থাকবে যে পেশেন্ট সেই ডেটা পেয়েছে ইন দেয়ার ওন ল্যাঙ্গুয়েজ। শুধু ইংলিশে কনসেন্ট ফর্ম দিলে হবে না, মানে সেটা পেশেন্টের ল্যাঙ্গুয়েজে
না,
কনসেন্ট ফর্ম।
তাহলে কি is it for a new molecule the consent should be changed accordingly? Because the consents for intravitreal injections are same for all molecules.
নিউ মলিকিউল যদি হয় তাহলে সেটা পেশেন্টকে আমরা জানিয়ে দিচ্ছি, দ্যাট মাস্ট বি রিটেন ওভার দেয়ার।
No, but if the new molecule is available and that is approved by the drug controller of India, তাহলে তুই নিউ মলিকিউল পাবি কোত্থেকে? If it is not,
It's sometimes
it cannot enter the Indian market.
sometimes a study doesn't include the South Asian subcontinent. It has happened.
But if it is an approved by
Approved,
director
obviously.
general, so
কোর্ট কোশ্চেন করছে যে তোমাদের সাবকন্টিনেন্টে ইন্ডিয়ান পপুলেশনে কি কোনো স্টাডি আছে?
That is what I was asking. Chalo, thank you. Let's move on to the next session. Over to Rupokda.
Anyway, this was very very interesting topic. যদি একটু কেউ জল চেঞ্জ করতে চান, জল চেঞ্জ করে চলে আসুন। And we'll move on to our next session. We'll request Chairperson Dr. K.P. Ghosh and Dr. Arup Chakraborty to be on the chair, please. And our panelists, Dr. Saurabh Sannal, Dr. Arup Kumar Bosh, Dr. Pinaki Nag, Dr. Debashish Datto, and Dr. Arindam Deb. So we'll move on for our first speaker, Dr. Rajarshi Ash. Rajarshi, there are ekhane? Oh. So ATD, related optic neuropathy. Fairly common for all practitioners we have come across, especially those who are senior. I think they have quite experience of having these kind of patients. So Rajarshida, if you tell us how to proceed about it, and then we will take the opinion from there.
Good afternoon to everyone. My topic is anti-tubercular therapy related optic neuropathy. Now, a 34-year-old male patient came to IOPD of Gauhati SA Hospital with gradual progressive paleness, deepness of vision both eye, and discomfort in bright light. No history of floaters or flashes, no history of using glass at present, no history of any systemic illness like DM, HTN, COPD, dysthyroidism or dyslipidemia. History of tuberculous cervical lipidinitis, received fixed dose combination of ATD for 11 months. Efficacy of cervical swelling over right posterior triangle reveals necrotizing granulomatous lymphadenitis, possibly of tubercular origin. Now, ocular examination includes visual acuity, figure counting at 2 feet in both eye, unaided, no further improvement with glass. Ocular movement, orthoporic, full, free and painless. Lids, conjunctiva, cornea and iris normal. Pupil size, shape and reaction to light both are normal. Now lens clear, NCT in right eye 14 mmHg and left eye 17 mmHg at 12.05 pm. Color vision, ECRS chart in both eyes 0/21 and ECRA with red filter 6/21 in case of right eye and 0/21 in left eye, and gonioscopy up to scleral spar in all quadrants. Now investigations. In fundus photography, bilateral pale atrophic disc. An MRI of brain imaging protocol, multiplanar images of brain were obtained in T1, T2, DW1, SW1 and FLAIR sequences, and post-contrast T1, 3D cube T1 and 3D cube T2 and coronal inversion recovery. Findings, no significant abnormality. An OCT of RNFL in both eye, superior, inferior and temporal quadrant, gross RNFL thinning. But OCT of macula, both eye is within normal limit. CMT in the case of right eye 274 micrometer and in left eye 270 micrometer CMT. And automated perimetry, advanced field defects in both visual fields. And in case of right eye, glaucoma hemifield test is outside normal limit. Visual field index 16% and left eye 21%, and mean deviation it is minus 26.47 and in left eye minus 26.62. And pattern standard deviation it is 5.47 and left eye 6.16. And visual evoked potential, near extinguished waveforms in both eyes, reduced amplitude and prolonged latency. And first one is 1.6 Hz, that is transient VP, and next report is steady state VP, that is 8 Hz. Now differential diagnosis. Toxic optic neuropathies, history of tobacco, ethyl alcohol, methyl alcohol, lead, carbon disulfide and quinine. And nutritional optic neuropathy, deficiency of vitamin B12 or folate, ruling out nutritional deficiency by blood test or assessing dietary intake. And compressive optic neuropathy, tumors or other lesions compressing optic nerve can cause visual field defect, necessitating MRI to identify any compressive lesion. And demyelinating optic neuritis, often seen in multiple sclerosis, presenting with acute painful vision loss and relative apparent pupillary defect, MRI is useful tool. And ischemic optic neuropathy, this involves reduced blood flow to optic nerve, leading to sudden painful vision loss, diagnosed by high SR, high CRP, automated perimetry, and temporal artery biopsy. A genetic optic neuropathy, like Leber's optic neuropathy, it is diagnosed by family history and mitochondrial genome sequencing. Now, treatment. Immediate discontinuation of ethambutol and monitoring, and supplementation with methylcobalamin and pyridoxine, etc. Stopping other medication like isoniazid. Isoniazid usually causes peripheral neuropathy, but no studies that it causes optic neuropathy. And linezolid, after the course of 28 days, it may cause optic neuropathy. And low vision aid and intravenous steroid therapy and plasma exchange therapy are other options. Plasma exchange therapy is the add-on therapy or last resort, in which case of neuromyelitis optica spectrum disorder, here the harmful antibodies are exchanged and by new blood or plasma was given to patients. Now discussion. All documents related to ATT were not there, not sure whether Benadon was supplemented or not. Ethambutol produces optic neuritis resulting in impairment of vision and color vision, especially for red ray. And optic disc is edematous and hyperemic with eventual central or centrocecal scotoma. The optic neuritis is dose dependent. It does not occur if dose is not more than 15 milligram per kg per day is administered. That it is upper limit of safety. Now, visual impairment can be severe and potentially irreversible if not detected and addressed promptly. Ethambutol-induced optic neuropathy manifests as painless, bilateral and symmetrical loss of vision, though sometimes it can present asymmetrically. And EON increases with higher doses of ethambutol and longer duration of treatment. The onset of EON can vary, but usually it often occurs after 3 to 5 months after treatment. And discontinuing ethambutol is the primary and most crucial step of managing EON. In some cases, early detection and prompt discontinuation of the drug may lead to visual improvement, but some patients may experience permanent visual damage. A regular eye examination at monthly interval, especially during ethambutol treatment or therapy, are essential for early detection of visual changes. It is believed to involve mitochondrial dysfunction and oxidative stress in retinal ganglion cell, as well as metal chelating property of ethambutol. Because ethambutol binds with the gene containing enzymes that are essential for biochemical reactions in cells. So the ethambutol binds with those enzymes and halts the different reactions within the cells. Thank you.
Thank you. I think this is very precisely is given there. There are any comment from?
Unfortunately, you will see a lot of patients that they come, they have not been counseled that this can happen, and this happened quite a number of times. That if you see less, come immediately or consult the ophthalmologist. That they don't know.
For the RNTCP program, I think this is in advocacy also. There is no protocol that every month it has to be checked or the vision to be checked. I mean, Shorabda.
Definitely, that has to be written by the physician.
And monthly
Every
interval,
monthly interval, visual acuity and color vision should be checked. I just want to give you a caution that there is a lot of prescription of linezolid nowadays because of atypical mycobacteria and other infections. And I have got 2 cases of linezolid induced optic neuropathy, and it was very, very severe, like this. So whenever patient is on linezolid, any patient comes because of other problems.
Now, what are the signs, Saurabh, in lineal toxicity?
Same like sudden or rapid onset of diminution of vision. I had a patient of cataract. He wanted to have cataract, but the amount of cataract was not corresponding to the visual loss. Then I started asking other history. Then he said, I was on linezolid for some atypical mycobacteria chest infection. And then I asked the physician to reconsider the drug. And he stopped the drug, and he improved after some time. And then we did, but it not improved up to the base level of 6/6. Around 6/12, the patient got vision. But he came to less than 660 vision with a very minimum amount of cataract. So those patients are on linezolid or ATD with cataract, please reconsider before surgery.
So do you think before the start of ethambutol they should have a vision check, baseline vision check as well? Because I had a patient.
No history of using any glass at that time.
Yes, because I had a patient who seen an ophthalmologist and asked to stop ethambutol, and then the doctor again sent the patient to me, and then I went through his notes. He was amblyopic for many years. So these are baseline should be yeah. And also the pulmonologist has to be aware. Like diabetologists, they previously didn't used to send the patient for retina examination for diabetes.
Yes, definitely. But something like Amsler grid, if it comes with the drug itself, pack of the drug itself, then you will be compelled to. Some people at least will be saved.
How often they really needs to be checked for the vision, color vision? Is it 6 months or 1 month, or is there a definite protocol? How often they need to be checked?
There is no protocol. That's what. Like there should be an advocacy of at least of monthly vision check. So it has to be, again. I mean, this is not the purview of today's discussion, but probably that is one of the protocol which we can, incorporate into it.
And in case we actually diagnose or just think it is the case, then shall we start the steroid just as a, whether definite role, or shall we start, or shall we send it back?
I think he has given.
The solution of the ethambutol, first step.
Yeah, that's
And after that, we can substitute other ATD or
Dr. Navanita?
after that, steroid or
because steroid in a patient of TB who are not already gone, then is very risky to start. So I think we
it is
shouldn't start. We
immunosuppressant.
should take the risk.
Flare up the
If it's not cleared up, then we start the steroid that can flare up very badly.
We can use another drug.
Running short of time, so we'll move. Dr. Vijit is not here today. And we'll move on to our next speaker, Dr. Navanita Borua.
So today my topic of discussion is the systemic medications that actually modulate angle closure glaucoma. So first I would like to run a case. 28-year-old nursing staff, she presented to our OBD with a history of diminution of vision, redness, pain. And on detailed evaluation, the patient said she had history of seizure and migraine for which the topiramate was advised, and she for a chronic migraine she went into depression, for which she sought another psychiatrist opinion who has started an antidepressant medication. Now after the first dose itself, the patient she was emetropic and she had no other complaint before this episode. Now she presented with this situation. On gonioscopy, the applanation tonometry showed it was a very high IOP 32, and the patient was put on topical steroid, anti-glaucoma medications, systemic and topical medications, and the patient was referred with the consultation of Department of Psychiatry. Immediately both the medication were stopped, and she was put on second generation on other form of anti-depressant medications. After 2 weeks, the patient has resolved all the signs and symptoms and improved. Now, what are the medication that causes bilateral angle closure glaucoma and the mechanisms? So, if we look at grossly, there are a lot of mechanism that has been explained, but we can grossly divide it into two. The patient who had already a pre-existing susceptibility to go into angle closure, and the medication that has pushed the patient over the edge to converse with a full-blown attack of angle closure. Our second would be a idiosyncratic reaction leading to a uveal effusion, leading to an angle closure attack. So first, we have anti-adrenergic group of drugs and anticholinergic group of drugs. And the second one, we have a lot of systemic medications which will go one by one. So at-risk population would definitely be with advanced age, female gender, strong family history, and any anatomical preposition like thick lens, cataractous lens, or any subluxation associated with collagen vascular disorders, any gonioscopically plateau iris syndrome. These things are to be taken into account. So as we can go ahead, a detailed systemic history and examination is very important, and investigation are there just to essentially give us the proper diagnosis. Ultrasound biomicroscopy and anterior segment OCT to look at various angles and to quantify these situations. So what are the history or drugs we essentially can look into? First of all, there could be a history of URI, and even nasal cord decongestant has alpha agonist, which is a stimulator. These are various anticholinergic drugs which is used in conjunction with systemic anti-asthma medication for urinary incontinence in female patients, in the elderly patients, even who are frequent traveler for motion sickness. Patients who requires recurrent kind of fundus evaluation for various fundus pathologies, and even for therapeutic use for cycloplegic. They can give an attack of angle closure if the angles are not properly evaluated. Anticholinergics, we have various anti-Parkinsonian drugs and glycopyrrolate that can be used for various systemic diseases. Now, scopolamine, it comes in various transdermal patches, and even in a prolonged use, it can have a chronic angle closure kind of picture. botulinum toxin with increased cosmetic use, it is the usage has been increased, and even after a routine cosmetic surgery, patient can have this kind of features if the patient has not been evaluated properly. Antihistaminic. Now coming to one important drug, that is cholinergic effect. Now there is a classification system which says that where the closure, the localization is most important. If the angle closure, the reason is at the level of iris, definitely cholinergic will affect. But if it is retroiridic, then the cholinergic can actually hamper the situation. So we have to use the pilocarpine very judiciously. Not all the cases of shallow angle we can go ahead and apply and advise the patient pilocarpine. It has to be a proper indication. Sulfonamides, as we all know, this in this situation, steroids and discontinuation of medication, they are much more effective. And even in this situation, cycloplegic can also have a role because it reduces the inflammation. Pilocarpine is essentially contraindicated in such patients. Serotonergic. Nowadays, the drug of choice for all kind of antipsychotic medication is SSRIs. As before, the TCAs were supposed to be more associated with ACGs. Nowadays, the improved or the newer versions of serotonergic, they are associated with less signs and symptoms of angle closure disease. So the list is very long, and each and every disease has some kind of effect on intraocular pressure, let it be anesthetic agents, anticoagulants, NSAIDs, or even appetizer suppressor. We see so many cases where with routine weight loss agents, they can have also various systemic side effects as well as increase in the IOP and possible attack of angle closure. So conclusion, we have to take detailed history and evaluation and investigation in proper cases, awareness of these situations in psychiatric patients, in psychiatrists, in general physician, even in ophthalmologists for combination therapy or wherever we are dealing multidisciplinary problems. This comes handy because these are many of the times unexpected side effects of these patients. So, and pilocarpine, although it is the drug of choice in most of the angle closure glaucoma patients, but if the problem is retroiridic, then we should be very judicious before using such patients. Thank you.
Navanita is a very well depicted talk. I mean, I think these are the drugs which we need to keep on our mind that whenever you see this kind of glaucoma. Any comment from seniors or, yeah. We'll move on to our next speaker, Dr. Anirban.
So, with acute attack of angle closure, madam, with acute attack, should we not use pilocarpine that time?
The classification system essentially says, sir, what is the reason for angle closure, that is most important. Like if it is a subluxated lens which is causing the problems, and in those situations, if it's the problems, they are retroiridic. Suppose there is a cyst behind the iris, there are ciliary processes. In those situations, putting pilocarpine will cause more of inflammation and more of infusion. So that's the reason. We have to evaluate and take a detailed history. And examination is required. We can take a UBM or anti-rosity pictures to actually localize the site of obstruction basically, and then use it.
Right.
Yes. Retroiridic, that is.
Okay, I understood.
So when you have to prescribe a drug like topiramate, what do you tell the patient? Suppose a patient comes with migraine and you have to use topiramate. Patient is not tolerant to flunarizine or other drugs. So what do you tell your patients that about the possible side effects? And how common is the side effect, this glaucoma and loss?
We don't prescribe to start with. It was an initial, but with more and more of medico-legal cases nowadays, we can only advise cycloplegic refraction at the max in the young patients, and definitely advice to the psychiatrist or a physician would be a better. We don't start topiramate on its own.
Migraine you can copy a way, but migraine you can start as an ophthalmologist. Just tell them
Or a follow-up, yes.
any drop of vision, sudden drop of vision.
Or redness or pain, we can come.
Sudden drop of vision, you should, the patient should report to you. Yeah.
Very good afternoon to all present here. So now you've all seen my topic. My topic has come from the fact that for the past few years I have been seeing a lot of misdiagnosed cases of allergic conjunctivitis and dry eye. So because of the significant overlap in symptoms, we'll try and make a simple differentiation here. I have no financial interests. So why does this matter? As I said, overlapping symptoms can often lead to misdiagnosis. Better outcomes are expected if we diagnose well at the first visit. The prevalence of dry eye is said to be about 5 to 50% globally, and allergic conjunctivitis is said to be about 40% in the general population. So the idea behind this presentation is try and find out key differentiators and diagnostic strategies. Now, I'll just rush through. This is a very simple presentation. See, it's an inflammation of the conjunctiva. It is often secondary to exposure to allergens. Commonly, we've seen pollen, pet dander, and we know the etiological classification. So there is perennial, seasonal allergic conjunctivitis, VKC, AKC, contact allergy, and giant papillary conjunctivitis. Again, dry eye disease, we know the Dewey's 2 classification and the definition. So it is a multifactorial disease. It is characterized by discomfort, visual disturbance, tear film instability, and there is an increased osmolality of the tear film with inflammation of the ocular surface. So etiologically, it is classified into aqueous deficient and evaporative. I will not go too much into the detail, but yes, there is an influence of your ambient factors, there is an influence of personal factors, aging, and some systemic drugs. So now, this is very important. So what is the difference between, say, a person who's coming with red eye and has a difference of symptoms? So itching is considered to be more common symptom in allergic conjunctivitis, but it is mild or rarer in dry eye. So grittiness is more common in dry eye, whereas it is considered to be rarer in allergic conjunctivitis. Photophobia can occur in both. Reflex tearing is more common in dry eye disease, whereas in allergic conjunctivitis you will get profuse tearing. The type of mucus discharge varies. It is very commonly stringy if present. Sometimes it is not present in dry eye. And in allergic conjunctivitis, it can be ropey or it can be watery. Intermittent blurring is often seen in my patients. I see them very commonly in dry eye disease, but it is sometimes seen in allergic conjunctivitis. Again, how do we differentiate between the signs? Conjunctival injection will be generally tends to be more severe in allergic conjunctivitis, whereas mild to moderate congestion can also occur in dry eye. Papillae, as we all know, it is more common in conditions like VKC, AKC. Now, this is important. The corneal involvement has a very characteristic pattern. So, in allergic conjunctivitis, the corneal involvement that we generally get to see is shield ulcers. But in case of dry eye, we see SPK, we say filamentary keratitis. There will be eyelid involvement in dry eye, so meibomian gland dysfunction, blepharitis. Whereas in conjunctivitis, it is often eyelid edema and associated dermatitis. Tear film breakup time is reduced in dry eye and it can be normal or elevated in case of allergic conjunctivitis. Very simply, the diagnostic tools that we commonly use, very importantly, we ask for try to find out the chronological history in the patient. We see what are the triggers to symptoms. Fluorescence staining, as I said, corneal involvement will vary with what we see in dry eye and what we see in allergy. T-Butt and Schirmer is generally reduced in dry eye disease and it might not be the same for allergy. Allergic testing is done by few, but it is an optional and it is often expensive, and in the peripheral centers you might not get an option to do allergy testing. Mebography will help to evaluate the meibomian gland function. Impression cytology is done rarely in cases where we cannot seem to find the cause. But yes, it will show a decreased goblet cell density in dry eye, and it will show higher rates of eosinophils in allergic conjunctivitis. Again, practical approaches to management. Now, of course, the differentiation that is being made here is important because from the patient's point of view, we need to understand what treatment, if given, will have the maximal benefit. So we know in dry eye that lubricants, preferably preservative-free artificial tears, are a better option. Allergic conjunctivitis, it is an adjunct therapy to what is your mainstay. Anti-inflammatories, we often use low-dose topical steroids, sometimes cyclosporin if necessary. Allergic conjunctivitis, we use antihistaminics and mast cell stabilizers. Environmental control is important in dry eye, but it is absolutely crucial in allergic conjunctivitis. Then immunomodulation is cyclosporin A, leafy grass, commonly used in dry eye. Now, an allergic conjunctivitis, we often use steroids and sometimes cyclosporin. I have no financial interest again, but just to give you an idea of what are the drugs used in both diseases. So we're gonna do a small exercise. So this was all about the basics. I'm going to show you two patients. So there will be one patient on the right side of your screen, one picture on the right and one picture on the left. Just by trying and looking at the picture, I want you to take a guess of what the probable diagnosis can be. We will discuss about what the symptoms are, what the history is. But just by looking at the picture, I want you to take a guess. So this is a case of a young adult. So any guesses? One of them is dry eye, one of them is allergic conjunctivitis. We will make it more simpler. Any guesses? So patient A, so this is patient A with the eye on the right is patient A, and patient B is dry eye disease. So I'll just give you a summary. So both of them are near about the similar ages. One patient, patient A, had symptoms worse in spring, history of seasonal allergy, intense itching, watery discharge, red eyes. The onset was of sudden onset, and it was generally during the March to August season that she was complaining that this was the problem. Exam findings, again, as you have seen, conjunctival injection, there might be small amount of chemosis, and there was papillae on the upper eyelid. There was a normal tear film breakup time and Schirmer test. So this is important. And if I compare it to the symptoms that in a similar aged female is, there is a history of long hours on the computer, no history of allergy. There was primarily gritty sensation, burning sensation, heaviness of the eyelids. There was intermittent blurring. There was gradual onset of symptoms which increased on using air conditioning or screens. There was mild conjunctival redness, and there is a decreased tear meniscus height. So Schirmer test and T-bar was definitely reduced in this patient. So we will move on to the second case. So again, patient on the right is one patient, patient C, and patient D on the left is, this is an older adult, above 60 years of age. So again, if anyone would like to take a guess. Right, so the right eye is, I'm sure you can understand, right eye is again allergic conjunctivitis, left is dry eye disease. See, again, the difference between the ages are not different, but if we come to the history, long standing seasonal allergy in the patient on the right, and then on the left, she was a postmenopausal woman who was on beta blocker systemic antihypertensives. Red on the patient C, allergic conjunctivitis, had red itchy eyes during her gardening session, whereas on the patient with dry eye had chronic dryness for a couple of years, which was burning, and it got worse throughout the day. So again, onset trigger, springtime exposure, increased allergic symptoms in the patient on the right, and on the left it was mostly age related, beta blocker used, and reduction of tear film associated with aging. Exam findings were also very different. So redness, tearing, some amount of eyelid rubbing was there. There were some degree of papillae that was seen on the patient with allergic conjunctivitis, whereas on the patient with dry eye we found gross conjunctival dryness. There was filamentary keratopathy. Then normal tear volume was seen in the allergic conjunctivitis patient, eosinophils on conjunctival scraping, and on the right, when we did a Shermer and Tibet, it gave us an idea what the case was. So this is case 3. So again, this is the final case. If anyone would like to take a guess, I think it's the easiest case of all the 3 that we've discussed. So the patient on the right, patient E, is actually a middle-aged worker with dry eye, and the patient on the left, patient F, is a case of allergic conjunctivitis. Now, the reason why I have brought these pictures along is whenever as ophthalmologists we get to see a patient, my teacher used to always say that the moment patient enters into your clinic and you get a first glance of the eye, you should be able to have a probable diagnosis in your head. Yes, sometimes it might not be right. Sometimes your exam findings might be different. But then again, this is very important. The patient F, both are again, as you see, similar age group. Patient F, the allergic conjunctivitis patient, had pets at home, and he was unaware that he was actually allergic to cats. It was only after we did an allergy screening, an allergy profile, that he found out. So this was a problem that he was having for years. Itchy, watering eyes, sneezing, nasal congestion, allergic rhinitis. Okay, there was a history of exposure to pets for the past 15 years. Lid edema was there on first presentation. There was a clear watery discharge, and there was normal or slightly elevated lacrimation. But in the case of the dry eye patient, so this was an office worker who was an IT professional. He always worked in an air-conditioned environment, had 8 to 10 hours of screen time, and he complained of burning sensation, heaviness in the eyelid, dryness, foreign body sensation, which was generally worse as the day progressed. Multiple punctate keratopathy was first observed on the first visit that he had come, and there was a low tear film, tear meniscus height. Again, Shermers and T-buds, when we did, we found it to be significantly reduced. Thank you. That was all.
Thank you, Anirvan. That's a very nice presentation with lovely photos. Shugatada. So for lack of time, I think we'll move on to the next speaker. If anyone have any important question or message to give or any comments to make, quick comments. English much thanda hoye jaye.
Very, very quick. Nice presentation. Only thing you mentioned about when you differentiate about the management of this, you said for the dry eye is steroid and lubricants, but for the allergic, you just put muscle stabilizer and anti-wasting. You haven't mentioned the steroid. But conditions which you showed won't get better if you don't use steroid. Steroid is one of the mainstay for allergic as well. Okay.
Sir, that is something I missed, I think.
Thank you. So, who will introduce Aniruddha? No introduction.
Good afternoon. Well, my topic is epiretinal membrane on vitreomacular traction, whether we need to follow up or surgery. See, this entity is pretty common. Nowadays, we do, mostly the patients undergo an OCT before a cataract surgery, and it should be done actually. Sometimes or rather majority times it is asymptomatic. But it is very important to document that there was some retinal findings like a vitreomacular traction before doing the cataract surgery. Later on, the patient might have complication due to the vitreomacular traction or a distortion following cataract surgery due to presence of epiretinal membrane. Now, what is it? The basic thing is an epiretinal membrane, it is sheet-like structure, as you can see in the first picture, that develops on the inner surface of the neurosensory retina. Now, what is the vitreomacular traction? Vitreomacular adhesion, when this posterior cortical vitreous is attached to the macula, but it is not causing any traction. It is just an adhesion, vitreomacular adhesion. And the last one is this posterior cortical traction is pulling the retina up. That is the vitreomacular traction. And what does it do? It can cause distortion in the vision, intraretinal cystoid changes. It might cause a macular hole following a surgery or a PVD, and even subretinal fluid in the macula that can result from the vitreomacular traction. Now, will not go into the details of the peritoneal membrane, but there are two concepts, like there's a long-standing hypothesis that the PVD results some micro breaks in the ILM, and from this breaks the retinal glial cells proliferate and causes an epiretinal membrane. Now, we get epiretinal membrane if there is no PVD as well. So the alternative concept is there is no break in the ILM, but the ERM may originate from the cells in the cortical vitreous remnants on the ILM, and that activates into myofibroblasts, resulting in a membrane formation, and there is a contraction. Coming to the VMT, it is the attachment of the posterior vitreous phase into the retina. Now, what is important, whether it is a localized vitreoretinal adhesion, vitreoretinal attachment, if it is a 500 micron, the length of the attachment, it doesn't cause much of a symptoms. But when this attachment has a broad attachment like 1500 microns, then it causes elevation of the macula. Even in a point, it can cause a macular retinal detachment. Now, ERM and VMT can be together. How is it? The ERM is adherent to the ILM, and then from the ERM there is an attachment of the vitreous. So the ERM is also there, and it also causes the VMT. Now, how do we diagnose? It is mainly a clinical diagnosis. We can see a glistening film-like structure over the retina in the epiretinal membrane. VMT, if it is not a very significant vitreomacular traction, we sometimes might miss clinically. That is where the OCT plays an important role. OCT can diagnose a fine, flimsy ERM and a VMT, which is not very significant and we can't see clinically. But this documentation is very important, even when we are doing a cataract surgery, beforehand the cataract surgery. What are the symptoms? As I have already mentioned, most of the patients with the epiretinal membrane and the VMT might be asymptomatic, but there can be loss in vision, metamorphopsia, that is a very common thing. There is a distortion in the vision and difficulty in using both the eyes together. The patient complains of diplopia. Now, coming to the management, follow-up or a surgery. Now, this data is very important. The patient should be informed that majority of the epiretinal membranes are relatively stable and do not require any treatment. If you go with the statistics, 29% of the ERM actually progresses over 5 years. But on the other hand, 26% has will have a regression, 39% will be stable throughout this 5 years time. So if you see, the more than 50% actually it doesn't progress or deteriorates. Rather, in some there will be regression also. If we see eyes of VMT of 1500 microns or less, the patients often have a very stable visual acuity, and there is an incidence of spontaneous resolution of the traction. And if you go with the data, it is 23 to 47% of the eyes if you follow up in a 1 or 2 years time. So there is a chance of spontaneous resolution also. So eyes, but the other hand, if the eyes, there is a cystoid changes at the baseline, they represent a cohort of patients which have a guarded visual prognosis. So the OCT will give us all this data. Is there any cystoid macular changes? Obviously symptoms, on the other hand, is the symptoms. And through the OCT, we need to see some certain criteria where we need to decide for surgery. Now, this is few of my patients. The first two are post-RT patient. You can see there is epiretinal membrane, but both of the patients are 6/9 vision. So we are not operating this patient. We are following up the patient. What is very important is you give a AMSL or grid, the patient will know when to come to you whenever they feel some distortion in the vision. The third patient is actually an CNVM patient. You can see with the anti-VEGF injection, the CNVM has it is subsided, but there is a vitreomacular traction, but it is less than 1500 micron, and we are observing the patient. This patient also has a 6/9 vision. Now, surgical planning, the decision to intervene surgically in ERM and VMT usually depends on the severity of the patient's symptoms. I think that is one point we need to emphasize, whether the patient is symptomatic. Now, what will be the symptoms? Mainly the symptoms will be distortional changes. The patient will have metamorphopsia, or they might have problem in doing activities of their daily life, like reading or driving. So if these are the symptoms, then we might plan for surgical. And patients with BMT do not typically improve without vitrectomy when the area of adhesion is more than 1500 microns. So that is a landmark, like that is a measurement we need to see whether it is a focal attachment or a broad base attachment. So overall, the recommendation is to observe or perform surgery is mainly based on the patient's discomfort and their vision. This is a small video. This is how we operate. It is fairly a simple operation, but we need to be very careful because in the vitreomacular traction, this is a case where there is a vitreomacular traction and epiretinal membrane coexistent together. We have to be very careful in actually inducing a PVD. We don't do a PVD in similar to the cases what we do in a detachment or a vitreous hemorrhage. Here we have to be very careful in actually separating the posterior cortical vitreous, because if we go ahead and pull it, we will actually create a macular hole, or rather an iatrogenic macular hole on table. So this is how we actually gradually tinge or separate the posterior vitreous, and you can see a little bit of tangential pull is done so that we can get rid of the posterior cortical vitreous from the fovea. Now we can see it is separated. Due to lack of time, I will just forward it. Now this was along with the epiretinal membrane. So we, after doing the vitreomacular traction surgery, so we have removed the we are removing the ILM ERM complex together. This is not a macular hole that we have to do an ILM peeling from arcade to arcade. Only the foveal part ILM peeling along with the epiretinal membrane removal is good enough. This was the pre-op picture and this is the post-op picture. And this is the pre-op picture of some of the patients. There's a vitreomacular traction. You can say the foveal traction is less than 1500 microns, but this patient had a symptomatic. He had a metamorphosis. The second patient was also symptomatic. Here there is a coexistence of epiretinal membrane and the vitreomacular traction, and these are the post-op pictures. So the take home, we are not going to the risk factors and all, but what is important is we have to do an OCT, which is very sensitive tool in picking up this pathologies and explaining the patient what is wrong and what needs to be followed. As Amsel agreed, is a very important tool which should be given to the patient. Patient should counsel the doctor should counsel the patient about the symptoms like metamorphosis or double vision or difficulty in using the eyes together. And on an average, approximately 80% of these patients with the ERM and VMT will improve at least 2 lines of visual acuity following a vitrectomy surgery. So the prognosis wise, it is pretty good, but we have to see which patients we really need to do a surgery. I think this is one of the entities where we are actually doing more surgeries. In some patients, conservative treatment is actually good enough. Thank you.
Thank you, Aniruddha. We'll request Dr. Dinesh to be there. But I think Aniruddha has put it in a very nutshell, in a very precise way. Yes.
Now, what is the risk of, how many patients with VMT develop macular holes during operation or after operation?
The good part is if we are aware that on table the vitreomacular traction has done an macular hole, iatrogenic macular hole, then we can obviously do an ILM peeling from arcade to arcade and put gas. So we can actually treat both the pathologies together, because the treatment of macular hole is ILM peeling from arcade to arcade and put a gas tamponade. But we need to be very careful in actually dissecting this vitreomacular traction.
Now, pre-operatively, when there is a vitreomacular traction,
now, Aurob's question is
What
different.
is the risk?
Your question is different. What is the progression rate from VMT to macular hole? This chance is very less. This is less than 10%. They progresses to macular hole.
The chance is less, but it can happen. So it is better to counsel the patient that you have some pathology. So later on, you might need a retinal surgery.
See, the confusion starts when you have a cataract along with these ERM, lamellar macular hole and vitreomacular adhesion or traction.
Do we need to guard the patient, or we should not be too
No,
aggressively guarded?
that's what, like, even this kind of patient, we do get referral that yes, this patient preoperatively, and now OCT is very much available, so in OCT it has been detected. Now, you have to judge how much actually that patient cataract is how much. So if the patient is grade 2 only and the patient vision is 660, so definitely you know that there is a significant drop. But yes, it may not match always together. So most of the time what I advise to the patient that there is no harm in doing this 2-stage surgery. You go ahead for the cataract surgery. If the patient is significantly vision improved and there is following up and there is no progression and the patient is improved to 612 or 69 vision with N6 and the patient requirement is not there, patient is not symptomatic, definitely we can follow them up.
I think if the patient is symptomatic, like the patient comes with distortion in vision and the patient has a significant cataract, then the combined surgery should be done. Otherwise, we can do the cataract and see, because you explain the patient, you have a retinal pathology, later on you might need a retinal surgery.
Sometimes the cataract surgery may resolve the condition also, right?
There is a chance of spontaneous resolution.
Spontaneous resolution is there.
Good afternoon to every senior, and thanks OSWB for giving this opportunity. So my topic is reimagining drying and durability with brolucizumab. So we all know that in the neovascular AMD and the DME management, fluid plays a very significant role. So this CSFT, that is central subfoveal thickness, and the fluid levels are very much important in the pathogenesis for both of the diseases. And we all know that the guidelines recommend that the treatment decisions are mainly based on the presence of the fluid on the OCT. So persistent fluid may lead to lower vision gain in both of the diseases, and even in the fluctuation in the CMT is also associated with the poor visual gain. So we need an agent that dries faster and better associated with the good visual acuity gain. So moreover, significant unmet need exists for many patients with neovascular AMD. As we have known in our daily practice, 70% of the patients are undertreated in the first year of the treatment. There is high injection burden around 50% of the patients, and 80% of the eyes receive 3 or less injections, that is suboptimal dosing. So an agent is required for maximum visual acuity gain with longer treatment-free interval. So coming to the DME, we all know that there is a famous study that has been done, that is Kestrel and Kite compared with the aflibercept. So in both of the study, it has been seen that the vision gain is quite comparable between the two groups, and the brolucizumab was quite non-inferior. But as we see in the OCT outcomes, that is decreasing in the intraretinal fluid and the subretinal fluid, and achieving the CSFT less than 280 microns was quite better in the first group. Here in the graph, we can see that the mean change in the CMT from the baseline, it has been seen that in the Brolu group, it was quite robust improvement in the 6 milligram studies, both in the Kestrel group and the Kite group. Whereas here we can see that in the bar chart diagram, that in both of the studies, Brolu group has achieved the CSFT less than 280 microns in both of the intervals, that is 52 and in the week 100, despite lower number of the injections. So what we need in our clinical practice, that we need more interval gap between the two injections, which was achieved with the Page-Next injection. So here in the bar chart, also we can see that the intraretinal fluid and the subretinal fluid in both of the groups was achieved more in the Brolu group compared to the aflibercept with lower number of the injections. Whereas in the post-hoc analysis of the Kestrel and Kite, that is, here we can see that the percentile of the patients achieving the dryness was quite more in the Brolu group compared to the aflibercept group. As we can see that in the week 100, 83% were achieved compared to 70%. And the time to achieve that the CSFT less than 280 microns, here we can see that in the first arm, in the both of the Kestrel and the Kite study, Brolu group have achieved quite more compared to the aflibercept group. So not only for the single period, but the important is that the time to sustain dryness, that we need dryness for 2 visits or 3 visits, that is called sustained dryness, which has been seen in both of the studies. Brolu group at all the intervals, that is week 52 and week 100, have achieved quite more compared to the aflibercept. So same as with the CSFT reduction. So the conclusion is that the greater percentage of the brolucizumab group achieve the dryness and also the sustained dryness in compared to the aflibercept group, and the time to first absence of the intraretinal fluid and the subretinal fluid was quite shorter. And by the week 52, more than 50% of the patients have achieved sustained dryness and CMT less than 280 microns. So coming with the neovascular AMD, this Hawk and Harrier study, we all know that it's quite a famous study, so which has been done and compared with the same aflibercept. And here also we can see that the Brolu group has achieved a quite comparable visual gain. But the most important thing is that we find very less number of the patients with the presence of the intraretinal fluid and subretinal fluid in both of the studies. So here we can chart, we can see with the graph that the stable CST reduction is quite important and with less fluctuation. So which is more important and which is more important for the visual acuity gain, which is we have seen in the Brolu group compared to the aflibercept group. This is a very important marker. Here we usually see in the OCT that the sub-RP fluid thickness, which leads to the poor visual gain. And it has been seen with this new molecule, there is a quite greater percentage reduction in the sub-RP fluid thickness compared to the aflibercept group. Also, the fibrovascular PED thickness has been shown with a greater reduction compared to the aflibercept in both of the studies, Hawk and the Harrier. So even with the lots of the number of the injections were given, but still some amount of the fluid was still present in the OCT, which is called early persistent fluid. But what most important is that even with those cohort of the patient, higher visual gain and lower CMT reduction is very much important. And here we can see with the bar chart that the Brolu group was quite good with the compared to the aflibercept drug. So the sustained dryness and with the less number of the injection, mark my point that less number of the injection is very much important, which we have achieved with the Brolu group compared with the aflibercept group at the week 96. So sustained dryness that is more than three or more than three fluid-free intervals in the OCT is achieved in both of the Hawk and the study and the Harrier study. For example, it is 91% compared to the 78% with the Brolu group and aflibercept group with the less number of the injections, which is very important in our daily practice. So coming to the summary, we can summarize that sustained vision gain with a small number of the injections were achieved. Treatment-free interval can be extended up to 12 weeks, that is 3 months, which is a very much important. Higher CMT reduction with less fluctuation has been seen, and it has the power of shown the more faster and more drying compared to the aflibercept group. Even with the 65% of the more patients gain more than 15 letters, even in the neovascular AMD patient with early persistent fluid. So, and it has also shown more reduction in the sub-RP and PD thickness. So it is a quite durable drying agent for the management of the both of the important diseases that is neovascular AMD and DME with a well-tolerated safety profile. Thank you.
Thank you, Dinesh. I mean, putting it very precisely, we'll move on to Debdulal's talk. Both of them are almost similar. But yes, brolucizumab, what he has highlighted is very nicely, is the smallest anti-VEGF available as of now today. So because of that, it has the very higher drying potential because it can penetrate the retina and go to the subretinal space where actually the neovascular membrane is located. So that's how is the potential effect of brolucizumab is the highest.
So thank you OSWB once again, and I'm holding you between lunch and my talk. So I'll try to finish fast. So I'll be speaking on aflibercept in DME management. This is the disclaimer. Now we've been talking about VEGF, but VEGF alone is not the only thing that is acting on DME and NAMD and some of the other diseases. So it's important to note that even with complete VEGF blockade, placental growth factor will still be available to bind with VEGF receptors, and therein lies the problem that you have those recalcitrant patients. 30 to 35% of all patients we know of DME and NAMD are non-responders, or maybe even more. So what's the issue here? Well, with diabetic retinopathy and diabetic macular edema, it's the placental growth factor that's still there. So these diseases have high rates of placental growth factor, and this has been amply proved. So poor responders to ranibizumab and also other anti-VEGF have elevated levels of placental growth factors, and this in turn gives rise to edema that is so often there, and especially in recalcitrant DME. Now, what are the guidelines for management of diabetic macular edema by some societies? Let's start with EURETINA. Now, the EURETINA guidelines recommend anti-VEGFs as first choice for treatment of diabetic macular edema for obvious reasons. And aflibercept is the drug of choice for DME with baseline vision less than 69 letters of the ETDRS chart. Now, most of our DME patients in India would be less than 69 letters, much lower than 69 letters. So probably aflibercept, if the patient can afford, is the drug to go with. Now, if you look at some of the evidence-based treatment recommendation for Asian countries from the Asia Pacific Council of Ophthalmology, then what it goes on to say in a summary is anti-VEGF therapy should be given as first line for patients with center involving DME in central vision loss. Number two, choice of anti-VEGF agents depends on the baseline vision. If the vision is good, you can do with any drug, but if the vision is less than 69 letters or less than 612, then you have to think about aflibercept, which is the so-called drug of choice. Early intensive anti-VEGF therapy is important for patients in Asia, and this will be amplified in some of the cases. Now, let's start with this patient, 59-year-old, naive DME, phakic, no evidence of cataract. Of course, a patient has also hypertension and some dyslipidemia. So you can see there's some exudates here, and you can see subretinal fluid and hyperreflective foci. So we started with aflibercept and statins. And this is how the patient responded after one injection. We gave the next one, and this is how the patient responded to the second injection, gave another. And this is how, after a gap of 2 months post the third injection, this is how the retina looks. You can see the exudates have disappeared. The edema is just beginning to come back, and maybe we can go ahead and give another injection, and the patient is doing fine with 6/9 vision starting from 624 at baseline. Now moving on to the next patient, naive patient, a simple routine case, if I may call, 40-year-old male, but so phakic, of course, clear lens, and the very name of steroids rang a bell in his mind. Na, steroid nebona, anything else. So he was fairly controlled, I would say, 7.5 HbA1c, and so we offered him aflibercept, and this is how things went. We gave him the first one, the second one, and the third one. So, and after the third injection, this is how the retina looked. Nice and neat, 6/9 vision, and you can see the fundus picture also, it's looking good. So after 4 months, patient came back with decrease of vision, and that's when we offered the next Eylea. And this is 4 months after the fourth Eylea. So you can see there's increase in the duration of action of the drug also. So it provides you durability, it provides you good efficacy, and this is 4 months after the fourth Eylea. So you can see here actually there's a little bit of fluid coming back. So that's when you probably need to give the next injection. Now moving on to some difficult cases. So this is a patient who had received 4 ranibizumab injections elsewhere and came to me, and I thought, okay, we'll do a little bit of focal laser and give a IVTA. But I burnt my fingers, vision improved, macular edema improved, but IOP was 45, and I had a tough time controlling the IOP. Thankfully, did not need a trabeculectomy. And from there on, it was ranibizumab, and more ranibizumab. After 8 more ranibizumab, this is where we were, and so I offered aflibercept. Patient thankfully agreed to take, and this is after the first Eylea, 1 month after the first Eylea, a lot of improvement, and you can see the vision is already getting better. So this is how things went. 2 months post first Eylea, hardly any fluid, and this is 3 months post the first Eylea, fluid is coming back, and we re-injected, and this is 1 month post the next Eylea, the second Eylea. 3 months post the next Eylea, that is to a second Eylea, no fluid practically. So we just observed. Another patient, again with ocular hypertension, youngish, 52-ish patient, and so lot of diffuse macular edema. You can see a lot of exudates, subretinal fluid, intraretinal fluid, everything. So after first ranibizumab, patient opted for ranibizumab biosimilar, I should clarify, and this is how things were. A lot of hyperreflective foci, some amount of decrease in the subretinal fluid, and this is after the second one. We added focal laser. I thought I had hit the nail on the head and did focal laser, and this is how the patient reacted. The fluid came back and came back with a vengeance. And then it was again back to more ranibizumab, and after 12 ranibizumab, this is how the patient was. So this time he agreed to switch over to Eylea, and this is how the patient was 2 months after the first Eylea. So you can see some amount of fluid. I offered the next injection, and this is again 2 months after the second Eylea. So there's little bit of fluid here which could be degenerative, But we went ahead and did the third ILIA, and 2 months after the third ILIA, you see there's no fluid. The retina looks nice and neat. Vision is 612. He's gained some vision, and he is happy with that. Now, why is this happening? Because pathogenesis of DME is extremely complex, and probably we don't understand it in its entirety. And it involves different metabolic pathways and retinal cytotypes, and the different involvement of the different pathogenic factors represents a relevant basis to understand the heterogeneous DME response to different intravitreal agents. So switching between anti-VEGF agents probably is necessary, and it's beneficial in many eyes. And to overcome tachyphylaxis, treatment with the same properties should stop for a while and switch to a similar drug could be tried. Now, aflibercept inhibits VEGF and PGF with higher binding affinity than their natural receptors and reduces disease activity in DME. And this is probably what actually does the job. Now, a little more difficult case. So this is a patient who has a strong very aggressive sort of POAG in the other eye. So, and patient came to us, and we saw some exudates here, but anyway gave an ILIA, and this is how the patient responded. The edema was going down, but the macular plaque was there, you can see from the fundus image, and we added statins and gave the second ILIA. So patient was very cooperative. One of the health schemes I should mention, and we injected the next one, and this is how the patient was after the second one. This is after the third one. And we injected monthly ILIAs. Patient was on one of those health schemes, central government health schemes, and this is after the third, gave the fourth one. Just see how the retina is changing. And of course, the statins also help. And this is how, the retina is looking better and better. We gave the next ILIA, fifth in 5 months, and this is how the patient looked. So would someone believe this patient had that macular plaque prior to, starting the ILIA? So sometimes we have post-vitrectomy cases which we cannot inject steroids for certain reasons, and so this is again a situation where you can use aflibercept or ILIA. And this patient had some hard exudates. I again added some statins, and this is how the patient responded after one ILIA, and this is how the patient responded after 2 ILIAs. And a lot of these patients actually stay good for a substantial amount of time. But as we know, diabetic macular edema is not a disease that usually stops totally, so you have to be on your guard. So we published, something a little while back. Some of my friends here are also part of this. Aflibercept versus dexamethasone implant for recalcitrant diabetic macular edema in pseudophakic eyes. Mind the word pseudophakic eyes. So basically what we found was that there was basically no, difference as far as the vision was concerned. No difference as far as the CMT improvement was concerned. But if you look into the fine print, you will have more PDR conversion with dexamethasone implants. You will have more patients needing laser with dexamethasone implants. So to summarize, aflibercept molecule has been specially designed to trap VEGF and PGF, which occurs at increasingly high levels with DME. Aflibercept, with its inhibition of VEGF and PGF, leads to disease modification in DME. Intensive treatment in year 1 can modify underlying disease and improve long-term visual acuity, and use of aflibercept is important in Indian clinical context considering the worst visual acuity of our patients. Thank you, and I guess lunch is ready.
Thank you for your hurried slide. aflibercept আর অ্যান্টিভেজেপ নিয়ে গল্প শুরু হলে এখানে কিন্তু লাঞ্চ শেষ হয়ে যাবে, সব শেষ হয়ে যাবে। অল্প খুব দু একটা ছোট ছোট প্রশ্ন যদি কারোর থাকে, অরূপদার একটা।
I have 2 questions for you, Devdulal.
Yes.
One is that you have said aflibercept plus statin. So do you prescribe statin yourself, or
Yes,
do you?
I play it safe. I go with very basic, atorvastatin. But if I have to give something else, I ask a physician or the
Now,
physician.
what is the dose you give? 10 milligram.
10 mg.
10
It's
mg.
homeopathic dose, but it works for the eye.
And I was talking to Rupak. He was saying that LDL level has to be reduced to below 50. Is it?
I think it is, it is recommended in many of the articles, but I do not always repeat the lipid profile after, say, 3 months or so. I do not always repeat. I ask the patient to follow up with his physician and inquire if my prescription is okay with the physician. That is also one thing I do.
because many of times I have referred the patient to cardiologist and they have said no.
No, they don't give.
He doesn't require.
don't give.
So this is one thing.
Yeah, yeah.
And another, this last patient which you have shown, there was a clumps of hard exudates on the macula.
Yeah, yeah.
These are the cases. Would you prefer dexamethasone or anti-VEGF?
Basically, if you have any glaucomatous tendency or glaucoma or IOP lowering agents already going, so then I opt for something
Not
else.
normally.
Normally we go for.
But
we
in
can
this
go for
patient,
dexamethasone.
you gave aflibercept.
Post vitrectomy with raised IOP. Post vitrectomy raised IOP, and if I remember right, 0.75 cupping with a superior notch.
So there was no aggregation of hard exudates on the fovea?
Yeah, there was.
No. After the injection?
No. Because patient was on statins, so that
But
also helps.
there are some people, they say there is a migration and
Yeah,
they
it
come
happens.
into the fovea and the vision, there's a visual loss.
Yeah, that is I showed in one of the patients. That is exactly what happened. But if you are like it has also come out in literature. If you are persistent with your treatment with anti-VEGFs, and if the statins or similar drugs are given, then there is a chance in 3-4 months the exudates they go away. So that is also there in literature. So many a times we are actually not able to give steroids, and we've been talking about consents. Patients do not readily give consent to a steroid. So that is another issue that we often face.
But the drug of choice is dexamethasone.
Yes, if otherwise if there is no contraindication.
Devdulan, if there is any exudates with DME, would you always recommend to put them on statin? And if it is, then what dose?
Not
Not as-
if it's lot of exudates, then only. Otherwise, if it is just 1 or 2 hard exudates away from the fovea, which I do not think clinically that it will come into the foveal area after an injection, I do not give statins.
But just for injections you give statin, or otherwise if only a few sort of exudates here and there, would you still not, before even injection, would you start them on
Yes,
statin?
I give statins and nepafenic eye drops.
What dose?
Again, it is 10 mg only for me. I do not give any high. I do not even go to rosuvastatin.
পিনাকিদা যে বেশিরভাগে কি হয় জানো তো, এদের না ট্রাইগ্লিসারাইডটা সাধারণত বেশি থাকে। ট্রাইগ্লিসারাইডগুলো এখানে কিন্তু হার্ড এক্সুডেটগুলোকে বেশি করে। সো ট্রাইগ্লিসারাইড ইজ ভেরি ইজি টু কন্ট্রোল। তুমি পেশেন্টকে একটুখানি হাঁটাহাঁটি করুক, একটু এক্সারসাইজ করুক, অ্যান্ড ডেফিনেটলি ইট ইজ গোয়িং টু কাম ডাউন, অ্যান্ড দ্যাট ডেফিনেটলি হেল্পস। রিগার্ডিং দ্য কোশ্চেন অরূপদার, যেটা মাইগ্রেশন সাবফোবিয়াল, তাদের ক্ষেত্রে চান্স বেশি যাদের একটা সিগনিফিকেন্ট এসআরএফ আছে। সো ইউ থিঙ্ক লজিক্যালি মাইগ্রেট করে ওটা ইন্টাররেটিনাল বা পাশে আছে, এসআরএফটা যেই মুহূর্তে ওটা রিগ্রেস করা শুরু করবে, দের ইজ অ্যান অটোমেটিক টেন্ডেন্সি টু কাম টু দ্য সাবফোবিয়াল এরিয়া। বাট ইয়েস, ইট হ্যাপেন্স ওয়েন ইউ হ্যাভ আ ভেরি র্যাপিড রেজলিউশন। That is more in case of anti-VEGF rather than this Ozudex. But aflibercept has a significant advantage because aflibercept has a longer duration of action compared to ranibizumab and other. So that's why it is better for being the diabetics. DME is a lifelong process. So the aflibercept has a major role of less number of injection in that way. I think.
Devdulal, you have given 17 injections of ranibizumab before shifting to aflibercept. Why is the reason for giving
The
17?
economics works out for biosimilars that way. Patients do not really agree that this is not a self-limiting disease and he or she will go on needing injections. That is the issue.
Shesh. Thank you. Pinakida. Vote of thanks.
Hello. Yeah, I think it's almost half. Everybody is hungry and is already on the way. But anyway, all is well that ends well. So hopefully after this all very, very interesting academic sessions we are going to have for the lunch. I would like to thank everyone who are present here today, and special thanks to Sudipta, who is at the center point of this, all organizing this, and we all helped her to get it a big success. The companies I would like to thank who have actually been helping us with this are the Entot. Special thanks to him. The food, if you like the food, is the Entot. They organize, they sponsor the food. So hopefully you will relish after all these academic sessions. And After that is the Sun Pharma, Zevira, Neomedics, Novartis, Bayer, Ajanta Pharma, and Sunwise all helped us for this beautiful morning and afternoon. Thank you everyone. Don't worry, Maj Bhaja, Ilis Maj Bhaja will be still hot. Don't worry, just a few snaps and then it'll be all after the food.